freak out. Now, again, as long as they're less than 50, we're going to think about an intraductal papilloma. These usually occur in the 40s. Now, they have these little tiny scopes, these little endoscopes, where they can actually look into the nipple ducts, and they can actually find it endoscopically. And then they can remove it because it's benign. Now, it looks like a papillary tumor. It's usually within the large lactiferous ducts or sinuses right under the nipple. Now, since it does have 2 layers, myopathy is still there, this is benign. This is a non-invasive lesion. So here's what it looks like. Here's the big duct. Inside it, you'll see this finger-like growth. This is a papilloma, intraductal papilloma. Now, you can imagine it getting twisted, right? If it gets twisted, it'll get ischemic, it'll infarct, and it'll bleed. So that's usually what happens. They come in with bleeding, and then you remove it, you're cured. Benign. Now, that brings us to the money. What's the most important lesion in this chapter? Breast invasive cancer. So invasive ductal cancers, those will be the most likely to be tested. Now, it's a very common tumor in women, and it's a big cause of death in women as well. Now, when I was in med school, it was 1 in 10 women, then 1 in 9. Now it's 1 in 8 women in their lifetime will get breast cancer. So if you have 8 friends who are female, 1 of them in their life is going to get breast cancer. See, I don't have to worry. I don't have to worry. My girlfriend will not allow me to have female friends, so I don't have to worry. I don't know any girls, so I don't have to worry. None of my friends will get it. I only have male friends. All right. Now, it's the second most common cause of cancer death after lung cancer, and it is increasing. And it's much more common in the U.S. than it is in other countries. Now, what if a Japanese woman comes to our country and lives here for 10 years? Well, then her risk of breast cancer starts to become the same as ours. So it's something about being in the U.S. Is it the water? Is it the food? Is it the chemicals? Is it the stress? We're very stressed in America. We're like on treadmills, just trying to make the mortgage. I know, we work. I learned this because of my Italian friends. My Italian friends say, John, we take like 3 months off for summer. You go to Italy in the summer, there's no one working. You're all on vacation. They take 3 months for vacation. Yeah. How many months vacation do you get as my resident? You get 3 weeks. That's all you get. You don't get a month. You get 3 weeks. Yeah, so you don't burn out. Give you a week or two, a week here, a week there, that's it. Yeah, so in America, we're working really hard. So maybe it's the stress. Who knows? But I know this. You're going to get this wrong. What's the number 1 risk factor for breast cancer? Being a female. 99% of breast cancers occur in women, only 1% occur in men. I know, right? So female's the biggest risk factor. Now, other big risk factors are aging. The older are more likely to get it. Exposure to estrogens, so long length of reproductive life, never having a break from pregnancy, obesity, exogenous estrogens, because estrogens are going to cause hyperplasia. And when it becomes atypical, that's a very big risk factor, atypical. And then, of course, a first-degree relative, that means a mother, a sister, or a daughter, a first-degree relative who gets breast cancer premenopausal. If your mother gets breast cancer at 99, that's mostly her age. Your risk of breast cancer is only slightly increased. If your mother gets breast cancer at 38, your risk of breast cancer is through the roof. So it's a first-degree relative with breast cancer in a menopausal age. All right, now about 5 to 10% of breast cancer are genetic. They're going to run in families, they're going to occur very young, and they can be very aggressive. So it's only 5 to 10%, but we can't miss these. So we're going to look for BRCA, BRCA1, BRCA2. Yeah, BRCA1 is when Angelina Jolie is missing. Yeah, her mother had ovarian cancer, so they checked her, and she was missing it too. Now, again, if you're born with a hit, you still need a second hit. So she just has an increased risk, right? Just because you have the mutation doesn't mean you're going to get the cancer 100%, but there's a high likelihood. So that's why she did mastectomy prophylactically and salpingo-oophorectomy. to try to prevent cancers, because BRCA1 is associated with breast cancer, ovarian cancer, and in the boys, prostate. And of course, what are the BRCAs important for? They're fixing DNA strand breaks. When you get strand breaks, it's BRCA who's going to fix it. That's their job, fixing strand breaks. So if it can't fix a break of DNA, you're going to accumulate damage in your DNA. You're going to get cancers eventually. Makes sense. Now, for BRCA2, it's a lot less common. We're only going to pick it when both sexes have breast cancer running in the family. So if it's males and females getting breast cancer, you start thinking about BRCA2. Now, in addition, they tend to get a lot of pancreatic cancers. Pancreatic. They get ovary? Yeah, they can get ovary too. But the most likely is breast cancer in males and females and pancreatic cancer. Okay, makes sense? Okay, these are the tumors. Breast, ovary, prostate. Breast, ovary, prostate. And then for BRCA2, breast in both sexes and pancreatic cancer. Those are the most likely cancers. Now, you can also get breast cancer in P53 germline mutations. That's called Li-Fraumeni syndrome. Remember, they get lots of bad cancers really young. They'll get breast cancer and colon cancer, bone cancer. They'll get it really young. That's when you think of Li-Fraumeni syndrome. Okay, now what about carcinoma in situ? Well, we think that's a precursor. So it's in situ still. It will become invasive if we leave it there and don't treat it. So we think that's a precursor. Now remember, if it's in situ, it hasn't invaded, how many cell types will still be present? Still two. If you only see one cell type, then it's invasive cancer. Okay? So in carcinoma in situ, we still see a basement membrane, we still see two cell types. But one of them is definitely still cancer. Now, if we don't treat this, 35% of women who have untreated ductal carcinoma in situ, they will develop invasive ductal cancer. Where? In the same quadrant. So that's why we think that this is a precursor, because they get cancer in the same area. Makes sense. That's why we have to treat this. Now, what about lobular carcinoma? Carcinoma of the lobules. Well, again, 35%, if we don't treat it, they will develop invasive cancer, but notice, it could be invasive lobular or invasive ductal. They can get either kind of cancer, and it can occur anywhere in either breast. So lobular is a marker that both breasts are at risk. It's like a field effect. You see lobular anything, both breasts have an increased risk of future breast cancer. Okay, so keep that in mind. All right, now where is breast cancer most likely to be found? Well, in the upper outer quadrant, just because there's more breast tissue, but breast cancer can occur any quadrant. Now, grossly, we're going to look for firm, stellate, like a crab, stellate, like a star or crab, as opposed to a fibroadenoma, which is perfectly round. That one's benign. This is invasive. All right, and it's very firm. It's very firm because of desmoplasia. The tumor induces a lot of fibrosis, and it tends to be gritty. So when you put the knife across it, it's like, it's gritty because it gets dystrophic calcifications. Very gritty because the knife's hitting those calcifications. All right, now we want to pick them up before they're palpable. They're palpable. They're big enough to spread. So I want to pick them up before they spread, because if it's local, I can resect it and you're cured. If it's spread, it's really hard to cure metastatic breast cancer. So we got to try to catch these early. So we try to screen. We try to screen by using mammography, and we're going to look for two things: dystrophic calcifications, and we're going to look for an architectural mass, right? This irregular stellate pattern. That's what we're looking for. So we want to pick them up when they're not palpable. They're small, because then we have a good chance of resecting them before they spread. Now, a bad finding is if you have nipple retraction or fixation to the chest wall. If it's fixed to the chest wall, you're going to have to resect ribs to get it out. That's never a good thing. Now, if I ask you, why does it retract the nipple and dimple the skin? The tumor is not grabbing the skin and pulling it down. The tumor makes fibrosis. The scars contract and they pull on Cooper's suspensory ligaments. The ligaments pull the nipple down. The ligaments pull the skin down. That's how they test the Cooper's ligaments. And it's the tumor pulling on them, and that's what causes the dimpling and the contraction of the nipple. All right, now what about the histology? What does it look like? Well, let's start with pre-invasive lesions first, the in situ lesions. Again, they have two cell types, two different cell types. We got ductal carcinoma in situ, and then the lobules can get carcinoma in situ, called lobular carcinoma in situ. Now, again, both of them are in situ. They're non-invasive, so you have preservation of that second cell layer. Okay, so two cell types are present until it becomes invasive. When it's invasive, you only see one cell type. Now, for invasion, always pick ductal. Invasive ductal carcinoma, because it's the most common type of breast cancer by far. Invasive ductal. Breasts make ducts, so you're going to see the tumor making ducts. So if we take a look here, duct, duct, duck, goose, duck, duck, duck. You see it making ducts. It's trying to behave, making ducts. Now, the problem is, if I stain it, the myoepithelial layer is usually gone. These are usually just the luminal cells. So that's how I'm going to know it's invasive. It's only one cell type. It's usually luminal. Now, question, what's it doing to the fat here? This is fat. It's just infiltrating. Breast cancer normal ducts shouldn't do that. Breast cancer infiltrates. These ducts are just infiltrating in and around and through the fat. They're just not making nice structures anymore, just making ducts, but invading. All right, now since most cases are luminal, they often have estrogen receptor positivity and progesterone receptor positive in the majority of cases. Now, these are important for therapy. In addition to standard chemo, which doesn't work very well, for the ERP or positive tumors, you can add the anti-hormonal drugs. Because if the tumor is using these receptors to grow, we can block them. We can block the hormones. So do you remember the selective estrogen receptor modulating drugs? Selective estrogen receptor modulating? Tamoxifen, raloxifene, very good. Because those are great drugs for slowing down this cancer. So we're going to add that to the chemo, but you can only do it if it has the receptors. Either one. If it has estrogen receptors or progesterone receptors, you can use these drugs. Okay, now the selective estrogen receptor modulator drugs are typically used when you have breast cancer premenopausally. If you have postmenopausal, instead we like to use the aromatase inhibitors. Aromatase is supposed to convert the androgens to estrogens. Well, if you block aromatase, you won't get the estrogens. Make sense? So we use that postmenopausally. Okay, so again, when do we use these drugs? Only if your tumor has the receptors for the hormones. That's when you use it. Now, about 20 to 30% of breast cancer have high HER2/neu, and that tends to portend a poorer prognosis because they tend to be higher stage tumors. In fact, for HER2/neu, about a third of them have already spread to the brain. That's why HER2/neu is bad. About a third of them are already in your brain. So HER2/neu in general is a worse prognosis, but what could I add to the chemo to try to help me? The anti-HER2/neu drugs. Trastuzumab, pertuzumab, we usually use them together because they're synergistic. Make sense? So again, when can I use these targeted drugs? If you have the target. So every time I diagnose breast cancer, I immediately stain it for estrogen and progesterone receptors to see if they're present, and I stain it for HER2/neu receptors to see is it normal or is it overexpressed. If it is, then we can use these drugs. Makes sense, right? All right, so always pick ductal. It's the most tested. Now let's do the exceptions too. But one last thing I want to show you in this picture. What's this pink stuff here? Ductal is the one that produces a lot of fibrosis. This is called desmoplasia. When a tumor induces fibrosis, we call it desmoplasia. And that's why these are firm. You can feel these. These are going to be palpable when they get big enough. They're going to be very firm. These you can feel. The woman's going to say, Doc, what is this? And you say, oh man, I feel it too. Let's get some mammography and biopsy. This doesn't feel good. You're going to feel these. Now, the second most common is invasive lobular, and it will be tested. Even though it's only 5 to 10%, the board likes invasive lobular because of the appearance. Now, first of all, it feels like edema. It feels like a thickening. It doesn't feel firm like ductal. It feels like a swelling. That's what it feels like. It's like vague. It feels like a swelling or thickening of the skin and underlying tissues. Now, when you remove it, you will see small, bland tumor cells. They look a lot like lymphocytes. But notice the way they line up. Lymphocytes don't form a line. They form this single file pattern. They line up. So you got these invasive lobular has these bland looking cells that line up. Now, since they do look like lymphocytes and it felt like edema or swelling, students will often confuse it with mastitis. It feels like a swelling and then it looks like lymphocytes. So they get confused. But lymphocytes don't line up. That's the key here. These are lining up. So this is an invasive lobular carcinoma. Now, my question for you is, why doesn't it make lobule-like structures? Why doesn't it make a round lobule like a duct? Why doesn't it do that? Because the adhesion molecules are knocked out. Do you remember epithelial, calcium-dependent, adhesion, E-cadherin? E-cadherin is knocked out in these lobular tumors. That's why they don't stick together and make nice lobules. They're just single cells infiltrating. Now, was there another tumor in the stomach that had single cells infiltrating with drops of mucus so it looked like a signet ring? Yeah, do you remember the diffuse gastric adenocarcinomas? They had the signet ring appearance. They also had E-cadherin. They also had it knocked out. That's why they're diffusely infiltrating as single cells. And by the way, since these are cells that can make some mucus, you can see signet ring cells here too. And they both can have signet ring cells. They both have single cells infiltrating, but one is in the stomach, one is in the breast. And don't forget, they both like to spread to the ovary. Lobular and stomach cancer both like to spread to the ovary. Interesting. They're very similar tumors. All right, now the problem with lobular, I told you, anytime you see lobule, check both breasts carefully because it's often multifocal and it can be bilateral. In fact, one of my surgeon friends, every time the biopsy comes back as lobular, he recommends that the woman do a prophylactic bilateral mastectomy. Now, that's a little bit aggressive, right? Most people will just watch both breasts very closely, surveil, but it just emphasizes the fact that both breasts are at risk for future cancer when you have lobular lesions. So you're like a ticking time bomb. A lot of women are not going to want to live like that. They're going to say, yeah, I'd like to have prophylactic mastectomy. Make sense? All right, so it's kind of controversial what to do because we like to practice evidence-based medicine, right? We don't like to guess. We like to do studies, right? They're not back yet. We don't know which is better, to do strict observation or to do prophylactic mastectomy. We have to wait to find out what so right now it's like an individual decision. You discuss with the woman, is she okay with surveillance or does she prefer to have prophylactic mastectomy? Right now we don't know which is best. We don't know yet. All right, now the good news about these tumors is they often have the receptors, so we can use anti-hormonal drugs. They don't have HER2/neu. They don't. That's good. That's good. High HER2/neu is a poor prognosis. So that's good. Okay, so those are the hormone status for these tumors. Now, all the other breast cancers are better. They're all better than ductal and lobular. So ductal and lobular are standard. All these other ones have a better prognosis, except for inflammatory. Inflammatory is the only one that's worse. Okay? So all these other ones have a better prognosis than ductal and lobular. Why is mucinous better? Because the tumor is on vacation. It's making a pool of mucus, and it's swimming. It's swimming. The tumor cells are bland, and they're swimming. Hey, I'm on vacation every single day because I love my occupation. Hey. Yeah, the beauty of medicine is we love what we do. It's not like working. Every day I show up because I want to see what am I going to see on the slide today. I show up to teach. What am I going to say today? What crazy story am I going to tell? I show up just to see what I entertain myself. It's not like working. It's beautiful. See, medicine is literally a calling. You're called to it. It's a wonderful thing. So it's every day I go to work. I love it. I love what I do. It's fun. Same thing with these tumors. They're making mucus and they're swimming in the mucus. They're not invading. They're not metastasizing. So this has a better prognosis because they're floating in pools of mucus. What else is good? They tend to have the estrogen receptors, progesterone receptors. They don't have HER2/neu. That's good. That's what we want. It's good. Now, the next one is tubular. Now, these are very rare tumors, but I love it when I see them because they're beautifully differentiated. They're making nice tubules like a breast should. They're very well differentiated. Therefore, they don't usually spread. Very rare to spread. Therefore, they're excellent. Too bad they're very rare. Now, they also have good hormone receptor panels. So they got the estrogen and progesterone receptors. They don't have HER2/neu. So great. They do really well. Now, the last one was surprising as a student. Medullary is ugly. It's pleomorphic tumor cells, and they fuse together and make syncytia. So you get these big groups. They're all stuck together, these large, ugly-looking cells with mitotic figures. They look horrible. So why is it better? Because your body realizes it's bad. You have a dense host inflammatory response. Your body's trying to fight it. So that's why this one's better. Even though it's ugly looking, it tends to have better prognosis because of the intense inflammatory reaction to it. Now, if this tumor spreads, though, it's not good when it spreads. So if it's local, good prognosis. If it's spread, it's not so good. Why? They're triple negative. They're negative for the estrogen progesterone. They're negative for HER2/neu. They're negative for everything. So if it spreads, all I can use is standard chemo, which doesn't work that well. There's no targeted drugs for this one. So better prognosis when it's local. When it spreads, it's not so good. And by the way, this is the type we often get in BRCA1 positive individuals. They often get these triple negative tumors that look a lot like medullary carcinoma of the breast. Okay? The prognosis is compared to ductal and lobular. So are these better or worse? These histologic types are better. The only exception is when medullary spreads. When medullary spreads, it's a worse prognosis. Okay, now the most evil one is a clinical diagnosis. It's a clinical term. It's called inflammatory breast cancer. This is the worst form. It's the worst. Why? Well, it looks inflamed. The breast is swollen. It's red. It's got all this fine dimpling. Looks like an orange peel. Because this is lymphedema of the breast. The tumor is in the lymphatics, blocking the lymphatics. So this is literally lymphedema. The tumor invades the skin, lymphatics, and you get this severe edema. So the breast is red and warm and edematous. It looks inflamed. It looks like a mastitis, except antibiotics aren't going to touch it. Antibiotics aren't going to affect this at all. It's lymphedema. Now, why is it the worst? Because if it's in your lymphatics, it's in your lymph nodes. It's already spread at the time of diagnosis. So metastatic breast cancer is very hard to cure. We'll still try, but the cure rate is very low when you have metastatic disease. Makes sense. And how do they describe this bumpy appearance to the skin? The peau d'orange. It looks like an orange peel because you got all the dimples on an orange peel. Now, when they ask you, why are these areas depressed? Why are they dimpled? Because as the breast swells, do you remember Cooper's ligaments? They attach to the surface of the skin and they hold it back. So as the most of the skin stretches, these areas are held back. That's what each one of these dimples represent. These are all the attachment sites of Cooper's suspensory ligaments. Wow, that's a lot of ligaments. Yep, that's what all those dimples are. They're the attachment sites of the ligaments. As the breast swells, those areas are held back. Makes sense. All right, so this is the worst one. Now tell me, which histologic type is it? It's usually ductal. It's usually an invasive ductal, but it's invading the lymphatics. That's why you get this swollen appearance. Makes sense? All right, now let's talk about when the tumor spreads up the ducts onto the skin of the nipple. You'll see this red, swollen, crusting appearance to the nipple. This is called mammillary pages of the nipple. Now, there's some sort of underlying tumor. It could be an invasive breast cancer or an incital breast cancer. It's usually a ductal cancer, and it grows up the ducts onto the nipple skin. And that's important because if I don't remove the underlying tumor, it's just going to recur. So you have to take out the skin with the tumor that's underneath it too. Now it presents as a red, crusting, oozing nipple and areolas. And under the microscope, when you do a biopsy, you will see adenocarcinoma cells. They're infiltrating within the squamous epidermal layer. Okay? Now to see them, they make some mucus. So you get a clear space. So if you notice, these cells here have a clear space around it. These cells here have a clear space around it. See the cytoplasm's clearer? These aren't squamous cells. Squamous cells, this is really pink. These are squamous cells. Pink cytoplasm. This is kind of pale cytoplasm. These are tumor cells. Here's some more. Tumor cell, tumor cell, tumor cell. And notice the way they're just percolating along. This is called the pagetoid growth spread. They're just single cells infiltrating across the skin. Now, question. It's in situ. There's no blood vessels here. Blood vessels are down in the dermis. So this is an in situ tumor. It can't spread until eventually it invades. Once it invades, now it can find a blood vessel and metastasize. But in general, most patch disease is in situ and it's not going to spread. So let's take out the skin, and with the underlying breast cancer as well, if we can get it out, we have a chance of cure. Make sense? What really is going to depend on is the underlying tumor. Is the underlying tumor invading and spreading? Okay, because this is usually in situ most cases. Paget starts from inside the breast, then it grows up the ducts to the nipple. Then here's the nipple skin and areola. So the tumor grows up the ducts onto the squamous epithelium here and just keeps spreading along to the areolas and just keeps going. Make sense? So it starts in the ducts, in the nipple, then the areola, and then to the rest of the skin. Just keeps going. All right, now let's talk about prognosis. Remember, the most important thing for the prognosis of most cancer is the staging. Grade is important too, but staging. So do you remember TNM? Always look for a choice that says metastasis. If you don't see any lesions that have spread out of the breast, then look for enlarged nodes. If you don't see enlarged nodes, look for tumor size, large tumors. So let's start with the nodes. The axillary area is where the majority of the upper outer quadrant will go. So we always check it on physical, and then we're going to remove lymph nodes too. Now, in the old days, they would do the mastectomy with a radical dissection. They take out all the possible lymph nodes, and there was a high risk of lymphedema. They get lymphedema. So we're trying to minimize that complication of taking out too many lymph nodes. So today we're trying to do a sentinel node, just to take out one, a sampling. Just take out one. So we'll inject the dye where the tumor is. Then the dye will go to the node that the tumor would drain to, and we'll take out just that node. Now, if this node is negative, what does it mean about all the lymph nodes behind it in the axilla? They're going to be negative too. So if the sentinel node is negative, you're done. You could say it hasn't spread. This is great. Now, if the sentinel node is positive, it's got tumor in it, well, now I have to do an axillary dissection. So if it's positive, we have to complete the dissection because I need to see, are the other nodes involved? I need to remove that tumor. So it's very important to take out the rest of the nodes to remove the tumor that may be there and to see how many nodes are involved. The more nodes, the worse the prognosis is going to be for the patient. Okay, so again, we try to minimize lymphedema of the upper extremity by trying to do a sentinel node. But in some cases, you have to continue to do a dissection, and you could get lymphedema. And then years later, what will happen in the arm on the exam? You'll get a lymphangiosarcoma. Lymphangiosarcoma because of the lymphatic obstruction for years. All right, now what about, we got the N, what about the T? The T is the size of the tumor. You usually use 2 centimeters as a cutoff between a low T score and a high T score. The bigger the tumor, the more likely it is to have a worse prognosis. Now, in addition to this staging, grading plays a role. Is it making nice glands? Is it making just sheets, not even trying to make ducts? So we want to grade it based on the appearance of the tumor. Also, the histologic type is important. Remember we said they're all better than ductal and lobular, except for the inflammatory one. So that plays a role too. Now, for treatment, we need the receptors. Receptors are critical to know, can we add the targeted drug to the standard chemo? So we look for estrogen progesterone receptor. If they're positive, you say, okay, now we can knock out the hormones. We can use it with the SERMs, or if they're postmenopausal, we can use aromatase inhibitors. Then we look for HER2/neu. If HER2/neu is overexpressed, that tends to be a higher stage tumor, so that's a worse prognosis, but we can potentially cure it by adding the anti-HER2/neu drugs. So there's several types of molecular breast cancers, but there's 3 you need to know. Are you ready? Here's the 3 molecular types of breast cancer. Okay, estrogen receptor, progesterone receptor, and then HER2/neu receptor status. Okay, the most common type of breast cancer is called luminal A. Luminal A. It's the luminal cells and tends to occur in older patients. Now, these are the best ones, luminal A. They occur in older people. They're usually having the hormone receptors, and they're negative for HER2/neu. So this is a really good one because we can use the anti-hormonal drugs, and they don't have HER2/neu. So when older women get breast cancer, this is usually the molecular type they have. Now, what's worse is about 20 to 30% of breast cancers have high HER2/neu. So we call these HER2/neu enriched tumors, HER2/neu positive tumors. Again, about 20 to 30%. Now, it's a worse prognosis because they're higher stage, and also because of this. We got estrogen, progesterone, they're usually negative, but they have HER2/neu that's positive. So since they have HER2/neu, they tend to grow quicker, and therefore they tend to be worse. But the good news is they're not the worst tumor, because at least I can use the anti-HER2/neu drugs. So this is the best molecular. This one is worse. But the worst one is negative, negative, negative. Because now I can't use any targeted therapy. These are called triple negative. They're the basal-like. Remember those basal myoepithelial cells? These are called basal-like carcinomas, like the basal cells, basal-like. Or triple negative. It's another name for it, triple negative tumors. These are the ones that are associated with BRCA1. They usually look like medullary type, and when they spread, there's not much we can do in terms of targeted therapy. We should use standard chemo, which isn't that good for breast cancer. Okay? So these are the molecular types. Luminal A, HER2/neu enriched, and then the basal-like, which are the triple negative tumors. Okay? I know we've done it a couple times now. I just want to put it all together in a table for you. Okay, so whenever you have a breast tumor, we want to look at these hormonal status to see what kind of molecular tumor we're dealing with, so we know not only prognosis, but we know what drugs we can target. Make sense? Okay. Yeah, medullary are the basal-like. They tend to be in the basal-like category. Very good. All right, now for men, we can get gynecomastia. This is when we have unilateral or bilateral benign enlargement of the breast of a male. Okay, so it's gynecomastia. Now, causes anything that messes up the balance and the force. So either not enough androgen, some low T, or you have high estrogen. Anything that favors estrogen over testosterone, that's going to cause the breast to enlarge. So physiologically, this happens to all male babies when they're born. When you're born as a male baby, you were exposed to mom's estrogen levels for 9 months. So all newborns that are male have slight gynecomastia. Also occurs at adolescence because the hormonal changing, you can get a little gynecomastia. And then it occurs as you get older and you get testicular atrophy and low T. Now, pathologically, it'll occur with cirrhosis because in cirrhosis, you're not breaking down estrogens. Klinefelters, they have streaked testes, they have low testosterone, they have unopposed estrogen. And they're pituitary tumors that make prolactin. Obviously, that makes the breast enlarge. Makes sense. Now, what about drugs? Well, spironolactone and ketoconazole are notorious for causing gynecomastia as a side effect. Now, here's a question that students will get wrong. When you have gynecomastia, the male breast is enlarging. What's proliferating? Is it the ducts? Is it the lobules? Or is it both? Okay, question. If men had lobules, women would make us breastfeed. You know they would. Come on, I'm pregnant. You got 9 months. Start stimulating your nipple. They would make us breastfeed. Our lobules are rudimentary. We're mostly ducts. So what's going to proliferate in gynecomastia? It's the ducts. Ductal hyperplasia, ductal elongation, ductal branching, periductal fibrosis. It's all about the ducts. Makes sense? We don't have much lobules. It's all about ducts. Makes sense. Now, question. I just said hyperplasia of the ducts. So what are males with gynecomastia at risk for? They now have an increased risk of breast cancer. Breast cancer. Okay, so increases the risk of males getting breast cancer. All right, we did really good here. Now we're going to talk about the males. For males, again, we're going to focus on the tumors, right? So testicular tumors and, of course, prostate tumors. Now, before we get to the tumors, though, let's have some fun with the penis. Question, the opening of the penis should be at the end, right? The urethra should go along the penis, and at the end, it should be the opening. So here's the urethra, opening at the end. What's it called if I have a congenital malformation where the opening is on the surface, the dorsal surface, the top? Well, number one, the baby's peeing in their own face. They're peeing in their own face. That is called epispadias. Now, if I ask you what causes it, you will say it is defective development of the genital tubercle. That's what causes it, defective development of the genital tubercle. You're peeing in your own face. Now, what if the urethra opening is on the bottom of the penis, so now you're peeing on your own shoes? They're peeing on their feet? That's called hypospadias. What causes hypospadias? Failure of the urethral folds to fuse at the bottom. If they don't fuse, there'll be an opening there. Make sense? That's cool. All right, now both of these are going to be associated with infertility. And that's for two reasons. Number one, the opening is in the wrong spot for the sperm to come out. And number two, they have undescended testes, which are cooking. So they're associated with infertility. And they're also going to have urinary tract infections. Why? Because bacteria only have to go from here to your bladder rather than from here. It's a shorter urethra, right? Opening is closer to the bladder. They're more like a female. So they have a higher risk of UTIs. Now, one more association. Epispadias. Do you remember it's associated with exstrophy of the bladder? So if the bladder, the abdominal wall doesn't close, your bladder's open, and then the surface of the penis can be open as well. That's epispadias. Make sense? Okay, what causes them? Epispadias is defective development of the genital tubercle. Hypospadias is the urethral folds failed to fuse. Embryology 101. All right, now for acquired conditions, if you don't clean properly, and if you have foreskin, you don't pull it back, you can get inflammation because all that dirt and oils and dead squamous cells, it's called smegma, that dirt, that leads to inflammation. So we call this balanitis, inflammation of the glands of the penis. And again, it's usually because you haven't been circumcised and you're not pulling the foreskin back and cleaning in there. If you don't clean, smegma, dirt accumulates and causes inflammation. And by the way, long term, if I irritate the squamous cells, you're at risk for squamous cell cancer. So this is one of the risk factors for getting squamous cell, having an inflammation of the penis for a long period of time. Now, what about Peyronie's disease? Not Peyronie's disease. You want Peyronie's. Peyronie's disease, that's fibrosis of the penis. What do scars do? They contract. No, gentlemen, what gives us pleasure? When it expands. So if a hottie walks by and it tries to expand, but there's fibrosis pulling it back, you're going to get a painful curved erection. Every time a hottie walks by, you're like, oh, just shoot me. Oh my goodness, what's the reason to live? So this is a pretty bad thing, right? Fibrosis, you get curved penis, very painful when you have an erection. And there's some treatments, but they don't work very well. One of the newer treatments is we're trying to inject in the penis collagenase. We're trying to inject collagenase to break down the collagen. Make sense? So you have to inject it into your penis and break it down. But the problem is you can also rupture the penis because you're breaking down the collagen. So that's one of the side effects. Interesting. So you don't want Peyronie's disease. Now, this has also been associated, by the way, with fibromatosis of the palms, palmar fibromatosis, and the soles, plantar fibromatosis. So you often get fibromatosis in those places as well. Now, for HPV, we know it loves the squamous cells of the genitals, so you can get warts, condyloma acuminata, these genital warts, due to 6 and 11. Now, if you get the high-risk subtypes, you'll be at risk for dysplasia and squamous cell carcinoma. That's the high risk, 16, 18, 31, 33, because of the viral oncogenes. Makes sense. Now, for squamous cell of the penis, there's another risk factor aside from HPV. It's people that have not been circumcised and they're not cleaning properly. They get a lot of balanitis. So those are the two risk factors, HPV and being uncircumcised, getting inflammation. Now, do you remember I told you that dermatologists like to use weird terms? What do you call it when you have in situ squamous cell before it's invasive? Well, I call it squamous cell in situ. Well, they give it funny names depending on where it is in the penis. They can call it a Bowen's disease or erythroplasia of Curat or Bowenoid papillomatosis. This is all fancy terms for squamous cell carcinoma in situ. I know. Why do they use these crazy names? I guess it's more things to test you on. All right, now what about the testes? A famous question is, a guy comes in with a unilateral mass in the scrotum. A unilateral scrotal mass, well, two things you need to do. You need to palpate it, and you need to shine light. You need to transilluminate it to see, is it solid or does light transilluminate through it? So those are two things you need to do for scrotal masses. Now, for varicocele, what's it going to feel like? A bag of worms. It's varicose veins of your spermatocord. They're dilated, they're tortuous, they're twisting. This is varicose veins. So therefore, it's going to feel like a bag of worms. It's not fair. What do women get? They get grapes coming out of the vagina. They get chocolate cyst of the ovary. They get strawberry cervixes. Ladies, your body is a wonderland. What does a guy get? A bag of worms. I guess it's fair, right? Sugar and spice and everything nice. That's what women are. Boys are puppy dog tails and snails and bags of worms. I guess that's fair. But remember the term, it feels like a bag of worms. Now, here's the key. It engorges when you're upright. Gravity brings blood down there. When you lay down, it should decompress. What if it's on the left side and it fails to decompress? You better check the left renal vein for renal cell carcinoma. It's a quirk in the anatomy. Only on the left will that occur. Makes sense. Now, what's another problem with all this heat? All this blood flow creates heat. The testes is cooking. So this is a surgically correctable form of male infertility. All that heat, you're not going to be able to make a lot of sperm with all that heat. So it can cause infertility. You may have to do surgery to correct. All right, now what if there's a mass in the scrotum and light shines through? Okay, if it transilluminates, it's either a hydrocele or a spermatocele. So is there sperm in there or not? That's going to be the key. Now, which is more common? Hydrocele. So if you don't know, the most common cause of a mass in the scrotum is a hydrocele. So if you don't know, pick hydrocele. For spermatocele, you're going to have to tell me there's sperm, because spermatocele is really just a dilated portion of the epididymis, or the epididymis. So that's what it really is. And it transilluminates like the hydrocele. Now, for hydroceles, it's too much fluid in the tunica vaginalis. Now, how did it get there? Well, the fluid is usually in your peritoneum. How does it get down there? There's a connection. There's a patent or persistent processus vaginalis. There's your anatomy question. If there's a connection between the peritoneal cavity, any ascites will come down into this area around the scrotum, and you will have this hydrocele. So let's repeat: patent processus vaginalis. Okay, makes sense? Will they talk about translumination? If they want to. So if they say it transilluminates, these are the two answers that are most likely. Okay? If it doesn't transilluminate, well, then it's more solid. So then you think about varicocele, or you think about tumors, then light's not going to go through a tumor. Make sense? All right, so you got to give me some clues if you want me to pick it. You have to give me enough clues so I know to pick it. All right, now what about inflammation of the epididymis, epididymitis? Well, that's going to be kind of painful. So you're going to get a fever, and you're going to get pain in the scrotum. Where? Well, the epididymis is in the upper back of the testicle. So that's how they'll describe it. Pain in the upper back of the testicle. They'll point right to where the pain is. Now, question: the upper back is where the spermatic cord attaches, so it's going to pull on that area. So what do the patients often do to their testes? They push them up. They come in holding their testicle up because it feels better. It's not stretching and pulling anymore. So this is called preen sign. Preen sign, where they come in pushing their testicle up. Feels better. It feels better when they elevate it. So that's preen sign. That's a good clue for this one. So fever, pain in the upper back of the testicle, and the testicle feels better when they elevate it. Preen sign. Now, what bug is responsible? It depends on the age. So if it's acute, you look at the age. If they're young, think an STD. Think an STD, chlamydia, gonorrhea. If they're older than 35, you think more E. coli. More E. coli. Now, if it's chronic enchesiating epididymitis, remember TB likes to go to the first structure coming off the testes. It loves to cause a chronic granulomatous epididymitis. All right, now what about inflammation of the testicle? That's called orchitis. Now, this is going to hurt everywhere. So you're going to get onset of fever, and the entire test is going to hurt. And it's often going to be caused by mumps. Mumps. Now, good news is it's usually unilateral. If it's bilateral, you could get infertility. So if both testes are inflamed, they could heal with scarring, you can get infertility. Luckily, mumps is usually unilateral. Luckily. Okay, now testicular torsion is one of the rare urologic emergencies. So if you go into urology, this is one of the emergencies you must know about. So this is when you're running around or moving around and your testes becomes twisted. So when it twists, not only do you twist the testicle, but the spermatic cord. So you're going to twist the arteries and the veins. Now, which gets compressed first? Which is compressed first? Is it the thick-walled artery or the thin-walled vein? The vein. The vein. So blood can come in, but it can't get out. So after 6 or 7 hours, the testicle will infarct and it'll be hemorrhagic. It will be a hemorrhagic infarct. So here's the rule. You have a golden 6 hours. 6 hours before this thing infarcts, approximately. So you got 6 hours for this emergency to untwist it. 6 hours to diagnose and untwist. So number one, how do I know it's torsed? Well, it's painful. It's ischemic. It's painful. And it's elevated. Why is it elevated? Because the spermatic cord is all twisted. So it's a painful, elevated testicle. Question, will elevating it more make... No, it's not going to help to elevate. It's already elevated. It's already elevated. Elevating more won't help. Okay, so that's an important clue from telling it from epididymitis. Okay, number two. What reflex is going to be lost on that side because you've twisted the spermatic cord and the muscle? You've twisted the cremasteric muscle. The cremasteric reflex will be lost. That's one of the key clues they like to give you. So a twisted testicle, you're going to lose the cremasteric reflex on that side. Now, the gold standard test is the ultrasound because the duplex, the Doppler setting, can look at flow. And you'll see decreased flow of blood getting into the testes. Make sense? So do the Doppler ultrasound, you'll see the lack of flow. Then you need to untwist it. You can try to do it manually, but most of the time you need a surgeon. You need a surgeon to not only untwist it, but to tie it down to the scrotum so it doesn't twist again. That's called orchipexy. Orchipexy. And by the way, they'll do it on both sides. But John, only this one was twisted. I know, we do it, we tie them both down. Because when you have a testicular torsion, it's often associated with a congenital anomaly where the testes is not attached. Remember the ligament, the gubernaculum ligament? It's missing in these patients. That is called a bell clapper anomaly. In my med school, they said, John, remember, bell clapper anomaly is a risk factor for torsion. And I'm like, aren't you going to explain what that means? What is a bell clapper? Okay, here's a bell. Do you remember the thing inside? Ding, 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 ding. That's a clapper. It claps the bell. Ding, 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 ding. It's a bell clapper. If the gubernaculum is missing, now the testy is going to go twisting away because there's nothing attaching it. So let's repeat. The bell clapper anomaly is when you're born without the ligament to attach it to the scrotum. You don't have the gubernaculum. So they call it a bell clapper anomaly, and it's usually bilateral. So if one side twists, when you untwist it and do orchipexy on the other side too. Tie them both down so it doesn't happen again. Makes sense. It's an emergency. You don't want to infarct your male brain. If you infarct it, you must remove it. I can't live without my brain. All right, now let's go to testicular cancer. This is the first 5-star thing in this chapter. They love testicular cancer and prostate cancer. Now, testicular cancer is going to present as a firm, painless mass that is intratesticular on the ultrasound. Now, question, will it transilluminate? No, it's going to be a solid mass. Enough light goes through it. So it won't transilluminate. And on the ultrasound, you'll see it's in the testes. Now, here's the rule. If I palpate a mass in the testes and on ultrasound it's within the testes and it's painless, that's cancer until proven otherwise. Painless intratesticular mass on ultrasound is cancer until proven otherwise. So you're going to have to do what's called a radical orchiectomy. You take out the testes with the spermatocord. Okay, so painless, intratesticular, radical orchiectomy is going to be done. Now, in terms of the tumors, we have seminomas versus non-seminomas. Now, non-seminomatous tumors tend to be worse because they spread quicker. They usually spread quickly, and usually they go to the retroperitoneal lymph nodes. Why retroperitoneal? Because that's where the testes descended from. Remember, the testis was in the retroperitoneum, then it descends down into the scrotum. So when testicular tumors spread, they spread to retroperitoneal para-aortic lymph nodes first. That's where they spread. And the non-seminomatous ones are more likely to spread. Now, who gets testicular cancer? It's usually Caucasians more than African Americans. It does run in families. So if your brother has it, it increases your risk. Now, another risk factor is hidden testes. Crep means hidden. Orchid means fruit, hidden fruit. So if you have undescended testes, they're hidden in your inguinal canal or retroperitoneum, you have an increased risk because they're cooking. They're cooking. So you have increased risk of infertility, increased risk of getting cancer. Now, another cause is dysgenesis, abnormal development of the testes. So if you have Klinefelters, you have streaked testes. They're streaked, they're irritated. So not only do you get infertility, but you have a risk of testicular cancer. Also testicular feminization because they tend to have undescended crypt orchid testes. They're cooking. All right, now in terms of diagnosis, you come in with a palpable and large testes. We want to do an ultrasound. We want to see, is it inside the testes or is it outside the testes? Now you're going to see intratesticular mass that is hypoechoic. It doesn't light up as well. Now, before we do the radical orchiectomy, what do we do before? We want to get your serum tumor markers before, because they can tell you which tumor is more likely, but more importantly, we want to know the marker before the surgery, so we want to see which one's elevated, and then after the surgery, we want that marker to go to undetectable. If that marker doesn't go down, that means you didn't get it all. There's metastatic disease. So we want the markers before the surgery so we can check them after the surgery to make sure they go down. Make sense? Now, which markers do we want to get? Well, we definitely want to get AFP. Now, let's be clear here. AFP can be elevated with several different tumor types, but the one you should associate with it first is yolk sac. Always think yolk sac tumors first. Other tumors can make it too. You also want to get beta HCG because it's made by trophoblasts, syncytial trophoblasts. So again, many tumors can make it, but the one you want to think about first is choreo. Always think choreo first. Okay, so if I see either of these markers, that indicates it's non-seminomatous. You better check the retroperitoneal lymph nodes because non-seminomatous like to spread quickly. Makes sense? Check those nodes, remove those nodes because it's likely to have spread. Now, what about LDH? That's a third marker we want to get. It's non-specific, and anything dies, it goes up. But if it goes up, it's going to measure the volume of tumor. So the higher it is, the worse the prognosis for the patient. So it's important for prognosis. So we'll measure all these markers before the surgery. And if any of them are elevated, we're going to check them again after the surgery to make sure that it goes down to undetectable. If it doesn't go down, you better look for metastatic disease. Makes sense. All right, so helpful for knowing which tumor we're dealing with and also important for making sure you get all the tumor out. Now, in addition to removing the testes, we may give chemo and radiation, particularly if we think it's spread. Now, the key is staging. So how far did it spread? We will check the retroperitoneal lymph nodes, make sure it hasn't spread there. Now, do you remember choreo? Where does choreo spread first? It's hematogenous. So don't forget to check the lungs too. Check retroperitoneal lymph nodes and check the lungs. So usually for staging, we do a CT of the chest to check the lungs for choreo, and we do a CT of the abdomen to look at the retroperitoneal lymph nodes, because that's what they spread. All right, now here's a good rule. Most of the testicular germ cell tumors, most of them are going to have isochromosome 12p. Okay, so let's repeat. Germ cell tumors of the testes and also the ovary as well. They have germ cell tumors there too. Most of these have isochromosome 12p. Now, what the heck does that mean? Okay, chromosome 12, P, petite. Do you remember chromosome 12 should have a short arm and a long arm? So there's a petite arm, and then the Q is the long arm, right? There's two arms. That's what chromosome 12 should look like. It should have a P and a Q. What does isochromosome 12p mean? It means in the tumor, here's what happens. Chromosome 12 has a short arm and another short arm. They got two short arms. That's isochromosome 12p. It's a chromosome 12, there's two short arms. So what happened to the Q? The Q is deleted. All the genes here are gone, so there must be some tumor suppressor genes there that are lost. And then now you have a double copy of the genes on P. You have a double copy. So maybe there's some oncogenes there. So let's repeat. When I see testicular or ovarian germ cell tumors, remember the genetic mutation is often an isochromosome 12p. Okay, keep that in mind. All right, now let's talk about the rule. Do you remember lung cancer? Lung cancer, we want to know, is it small cell or non-small cell? Yeah, because small cell is the one that spreads quickly. You can't do surgery. It's got a worse prognosis. Same thing here. Is it seminoma or is it non-seminomatous? Seminomas are much better. Seminomas spread late. They stay usually localized, good chance of cure. They're much better, much curable. Non-seminomatous are more aggressive. They spread quicker. They have a worse prognosis. So again, you need to know, is it seminomas or non-seminomas? Prognosis is different. Now, the good news is, what's the most common testicular tumor in our age group? Seminoma. So when you see kids, young adults, older adults, so basically 20 to 60, you think about seminomas. They're most common around 40, but anywhere from 20 to 60, you think about these seminomas, which are excellent. The reason they're excellent is after the surgery, they respond both to chemo and they're very radiosensitive. You got 3 ways to kill it. Surgically remove the mass, then give chemo radiation. They're usually excellent. The cure rate is over 95% because most cases are caught early before it spread. Does that make sense? Okay. Oh, yeah, we need a break, don't we? Okay, let me finish this. Let me finish this concept. We'll take a break. Sorry, I'm excited. I'm excited. It's the last day. Okay, now these are usually 20s to 60s. Question, can I see these in old people too? Yeah, older people tend to get a variant. It's called a spermatocytic seminoma. Spermatocytic. It's a disease of older men, but it's still excellent. So even when it occurs in old guys, we change the name. It's still excellent. Now, grossly, what do seminomas look like? Well, they're large. They're large, bulging tumors. They don't have necrosis and hemorrhage, though. So they're malignant, but they're just not very aggressive. Now, for the microscope, there's a cool appearance. You'll see these monotonous cells with clear cytoplasm and round nuclei. So what do they look like? See the purple dot? And then it's got clear cytoplasm? Purple dot, clear cytoplasm? Tell me they don't look like fried eggs. They look like fried eggs. So if this was in your brain, you'd say, let go my ego, oligo. Looks like an oligodendroglioma if it's in this brain. If it's in this brain, you call it a seminoma. They look like fried eggs. So we see these nests of these clear cells. Here's another nest over here. Now, in between are these septae. See these fibroseptae here? Fibroseptae, they're pink, fibroseptae. Now, in this fibroseptae, we see some purple dots. These are lymphocytes. See, your body's fighting it. Another reason it's good prognosis, you have lymphocytes attacking it. So this is a good prognosis. Lymphocytes are here. You may see some granulomas, and you may see some giant cells that can produce beta HCG. So 5% of seminomas have elevated beta. No, John, I heard beta HCG is for choreo. Yeah, always think choreo first. Choreo almost always has high beta HCG. But 5% of seminomas can have high beta HCG as well. Oh, markers aren't 100%. Okay, so we got to know what's most common, and then we should know the exceptions as well. Okay, now, all the other testicular tumors are called non-seminomatous. So embryonal, choreo, yolk sac, teratoma, those are more aggressive. So we'll take a break, then we'll come back and we'll talk about these more aggressive types. Okay, any questions so far? Fried egg in the ovary? Dysgerminoma. It's a seminoma. They call it dysgerminous. Let me go back here and I'll just put seminoma equals dysgerminoma in a woman. The same picture, same everything, except the prognosis is slightly worse just because they're internal. They're going to get larger before you detect them. So if they're larger, they have an increased risk of spreading. Makes sense. What's the difference between germ cell and sex cord? Sex cord are the stromal cells. So in the testes, what's the supportive cells? What are the nurses for the sperm? Do you remember the Sertoli cells? And then the cells that they're Leydig cells, the ones that make the testosterone, those would be called the sex cord stromal tumors. Tumors of the Sertoli cells, tumor of Leydig cells, those are sex cord stromal tumors. Make sense? The ovary has sex cord stromal tumors. The testes can have sex cord stromal tumors, but the most common are the germ cell. The tumors are the actual germ cells. Okay? Okay. Yeah, you got it. Fried eggs. So we think of fried egg appearance to tumors. If it's in the brain, oligo. Your testes, seminoma. Your ovary, dysgerminoma, which is a seminoma, really. You just changed the name. Why is it elevated? Because how does sperm leave the testes? Well, it's made in the testes, goes to the epididymis, and then goes up the spermatic cord, right? Goes up. Well, they're all connected. So if the epididymis gets inflamed, it's attached to the spermatic cord. So as the cord pulls on the epididymis, it's going to hurt if the epididymis is inflamed. It hurts. Pull on it, hurts. So if they raise their testes, that traction is gone. It feels better. So if you raise an elevated testes when there's inflammation of the epididymis, it's going to feel better because it's not being tugged on. Does that make sense? They're all connected. Okay, what's Li Fermini? Germline mutation of P53. You were born with one p53 knocked out in every cell of your body. So the risk of highly malignant tumors like colon cancer, lung cancer, breast cancer, sarcoma is through the roof. Yes, break. We're on break. I'll see you guys in a few. 10 minutes. All right, my warriors, hour number 2, so far so good. Is hyperplasia reversible? Yeah, hyperplasia is reversible. It depends on the degree. Obviously, the more hyperplasia, the more difficult it will be to reverse. But in general, hyperplasia is a reversible adaptive change. All right, now let's get to the more aggressive testicular tumors, embryonal. What's an embryo? Well, it's supposed to divide and divide and divide, grow rapidly. Embryonal rhabdomyosarcomas, they're undifferentiated. They grow very rapidly. So they're more aggressive than seminomas. They tend to occur in adults, usually mid-20s and 40s. And they're going to be large, bulky masses with hemorrhage and necrosis. Now, they have large, primitive, undifferentiated cells. So as a question writer, what's unique? Any buzzwords here to test you on? Just embryonal's primitive and it's aggressive. It spreads quick. There's nothing sexy to write about. What's sexy is choriocarcinoma and yolk sac, endodermal sinus tumors. Those are high yield because for chorio, it's one of the most malignant of the germ cell tumors because it spreads quickly, hematogenously. It's different than all the other ones. This one's going to spread to the lungs first. So this is why we check the lungs. Then it goes everywhere. Liver, brain, bone, it goes everywhere. Do you remember Lance Armstrong, the guy who won the Tour de France? He cheated. But guess what? He had testicular cancer, and one of the components he had was chorio. That was the one that was in his brain. It was in his bone. It was everywhere. Makes sense. It spread all over the place. Now, there may be small primaries because they spread quickly. So the mass in the testes may not be that big, but they spread very quickly. Now, for the microscope, we'll see syncytial trophoblast. That's what makes the beta-8-CG in very high levels. And also cytotrophoblast as well. Now, question, what's that beta-8-CG going to do to a guy? Well, number one, if they accidentally do a pregnancy test, it will be positive. He will have a positive pregnancy test. And number two, gonadotropins, gynecomastia. So there's 2 testicular tumors where you'll come in with a mass in the testes with gynecomastia. Chorio is one of the 2. We'll talk about the other in a moment. So you got to know chorio with gynecomastia. So positive pregnancy test. By the way, they can get morning sickness. They can get hyperemesis because of this beta-8-CG. Now, Lance, if you read his book, his testes was enlarged. It was like the size of an orange, but it's painless. See, if it's painful, guys would come in. Painless, we ignore it. He thought it was, it's the bicycle seat. I'm on the bicycle seat all day long. It's probably irritation. I wish the other one would get big, but just one big, all right. Didn't hurt. He didn't come in. But the chorio spread to his lung. He started coughing up blood. That's what brought him in. He said, Doc, I'm biking all day. I'm using my lungs a lot. I think I have pneumonia because I'm coughing up blood. Oh, let's do a chest x-ray. Dude, you got metastatic nodules in your lung. I wonder where the primary is. Doc? It's like, dude. He goes, yeah, I just thought it was the bicycle seat. It didn't hurt. I know. Crazy, huh? So people ignore things. And by the way, that's how he was such a good cheater. Because choriocarcinoma requires chemotherapy, it will respond. It'll melt away with chemo. It requires a lot of chemo. Now, when you give a lot of chemo, you knock out your marrow. So what do you need to grow your marrow back? You need recombinant growth factors. That's how he learned how to blood dope. Because of the chemo, he had to learn to give erythropoietin to himself. He knew the half-life. He knew how to adjust. So he knew how to get away with cheating blood doping because of the cancer experience. So he's a hero for surviving this tumor because chorio is very aggressive. But obviously he cheated after it. That's not cool. All right, now what about yolk sac? Very testable. Yolk sac is sometimes called endodermal sinus tumor by question writers because if there's 2 names, they always use the name you don't know. Now, this is a testicular tumor that is very common in the young. So I always remember young yolk sac. So if a 3-year-old has a mass in their testes, young yolk sac. Now, adults can get it too, but for adults, no, they're not pure. For adults, it's usually mixed. So Lance, he had chorio and yolk sac. They were both in his testes. Which is the one that spread? It was the choreo that tried to kill him. The choreo. So for adults, the prognosis depends on what it's mixed with. Okay, so this is not usually going to kill you. It's what's mixed with that can kill you. Now for yolk sac, under the microscope, it tries to recapitulate a yolk sac. So do you remember the job of the yolk sac is to absorb the yolk and feed the fetus, right? So it's got these glomerulus-like structures, except the glomerulus is supposed to filter and secrete stuff, right? This is going to be absorbing. So it looks like a glomerulus, but it's like the reverse of a glomerulus. They call these glomeruloid structures Schiller-Duvall bodies. Buzzword. Now, the other buzzword is these tumors make high levels of alpha-fetoprotein. It will be elevated in the bloodstream, and it'll be elevated in the tumor. You can see globules of AFP within the tumor cells. So AFP, very important marker here, alpha-fetoprotein. So those are two important and very testable buzzwords. So question, if I say to a student, a testicular mass has Schiller-Duvall bodies, they're like, is that Leydig cell tumor? Was that Sertoli? Which tumor was that? So we need a way to remember this. So I just look at the name. Schiller. Chiller. In your house right now. What's keeping your food cold? What is the chiller of your food? The refrigerator. What's in your fridge right now? A dozen eggs. Isochromosome 12p, a 12-pack of eggs. You got a 12-pack in your chiller. So this is his isochromosome 12p mutations. It's got Schiller-Duvall bodies, and it's got alpha-fetoprotein. Makes sense? So Schiller, every time I see Schiller-Duvall, I'm like, chiller? Oh, eggs, egg yolks in the chiller. I don't miss it because of that silly mnemonic. All right, now what about this tumor? It's cystic. I open it up. I see a matted hairball. A matted hairball. Oh, there's a tooth. There's a tooth. Got a little cavity. So some teeth, some hair, some thyroid tissue. Sounds like a scrambled baby. This is a teratoma or dermoid cyst. Women get them. They're benign. Men get them. They're all malignant until you prove it's not. So for men, they're usually bad. They're usually malignant. But they're cystic. They got cartilage and bone and teeth and hair. They're like a mess. Now, they can have ectoderm, mesoderm, and endoderm. They can have all three layers, and they're all scrambled, like a scrambled baby. Now, unfortunately, they can be benign, especially when the males are young, but most cases in adults are going to be malignant. Which part will turn malignant? Well, it's either going to get squamous cell carcinoma or gliomas. See? This is more proof that it's a male brain because you get brain tumors there. You get brain tumors in your testes. It's just more proof. I know, men have two brains. All right, now most testicular tumors in real life are mixed. Like Lance Armstrong had a mixture. So mixtures are common. So 60% of testicular tumors are going to be mixed with more than one subtype. Now, a famous combination is to have a mixture of a teratoma and embryonal. So do you guys remember when, you had Brad Pitt and Angelina, they called them Brangelina. And then you have Jennifer Lopez and what's his name, Batman, Ben Affleck. So they kind of combine the names together, right? Bennifer. So when they combine names, it's kind of sexy, right? So teratoma plus embryonal, that's a common combination. So they call it a teratocarcinoma. So embryonal carcinoma with teratoma, they just put it together because they like to be together, these two. All right, now somebody asked me about the sex cord. Can you have sex cord stromal tumors in the testes? You have them in the ovary. You can have them in the testes too. So these could be tumors of the Leydig cells, tumors of the Sertoli cells. Now for your exam, it's the Leydig cells. That's the one they like. Again, painless intratesticular mass on the ultrasound. Now, for Leydig cells, they're bimodal. You can get them very young, prepubertal boys, and you get them old. Those are the two populations. Now, since Leydig cells make androgens and estrogens, in a prepubertal boy, those androgens are going to cause precocious puberty. Dad, can I use your razor? Son, you're only 8 years old. I know, but I got to shave. I'm playing on the football team. They get precocious puberty because of the androgens. But most cases are in older guys. Question, older guys, are you going to notice the androgen? No, my voice may get deeper. I may grow more hair, but I'm already hairy. I already have a deep voice. It's hard to notice. Are you going to notice the estrogen? Yeah. So this is the second tumor in the testes that will give you gynecomastia in the older population. So let's repeat. If I see a testicular mass with gynecomastia, I'm thinking, is it choreo because of beta HCG? Or is it a Leydig cell because Leydig cells make estrogens? Okay, so that's my differential when I see a testicular mass with gynecomastia. Now, fortunately for Leydig cell tumors, is they're mostly benign. Okay, so you take them out, you are cured in the majority of cases. Wonderful. But there is a cool histologic feature. What do we see in Leydig cells? Well, they're large cells. They're very pink, like a lady. So Leydig cells are like ladies. They're very pink cytoplasm. And then you'll see these pink crystals, these pink rods. These are called Ranke crystals or rods of Ranke crystals. So those are kind of a cool like feature to find. So a pink cell with these pink inclusions like rods, those are called the Ranke rods, rods of Ranke. Okay, makes sense? Can you see seminoma giving gynecomastia being because of the beta HCG? The levels are not usually that high. They make a little beta HCG, but not like a choreo. Choreo makes really high beta HCG. You can wind up with gynecomastia. So potentially, could you? Yeah. Have I ever seen a case of it? No. I've never seen a seminoma with gynecomastia. But it's theoretically possible because it can make beta HCG 5%. All right, now let's talk about this one, the prostate. For the prostate, tumors are going to be the king. But we should also know about BPH because as guys get older, you're going to see this all the time. This is nodular hyperplasia of both the glands and the stroma. So the gland's going to get big. You see nodules in the prostate gland. Now, it's incredibly common as we get older. Now, when they ask you what causes it, you're going to say too much androgens, specifically dihydrotestosterone. That's what seems to be a major mediator here. Now, it's not the testosterone, it's dihydro. How do you make dihydrotestosterone from testosterone? 5-alpha reductase enzyme. So question, if I ever wanted to shrink your gland back down to normal size, what could I give you? A 5-alpha reductase inhibitor, like finasteride, right? Finasteride would shrink it back down. So keep that in mind. That's how the prostate grows. We can stop the growth and reverse it by getting rid of this enzyme. Makes sense. All right, now as we get older, all men are going to get it. So by age 60, 70% of us will have it. By 70, 80%, if we live to 120, it's almost 100% will have it. Now, what is it going to cause? Well, if you remember, your bladder sits on your prostate gland. The bladder. So to empty the bladder, the urine has to go through the prostatic urethra. As the prostate gland gets bigger, you crush the urethra and you get, I can't pee, doc. I can't pee. You get urinary obstruction. You can't pee. So they're going to say, doc, when I pee, I got a very weak stream, a decreased caliber stream. I have trouble starting and stopping. I get a lot of dribbling. Oh, I never feel like I'm done. I'm like, I dribble a little bit, then I go back and I can wake up again, go dribble a little bit. They're never quite done. So they got a lot of urine sitting in the bladder. So the risk of getting UTIs is going to be increased now, right? They get some incontinence of urine, especially at night. They get a lot of nocturia. They get frequency. They're up all night peeing. These guys can't pee. It's very frustrating. Now, PSA. Is PSA specific for the prostate? Yes. Is it specific for prostate cancer? No. So it'll go up with prostate cancer, but it goes up with BPH too, because the volume of tissue, the more PSA is made. Now, it's going to be elevated, but it's usually less than 10. If it's over 10, you have to rule out cancer. Okay? So BPH, the PSA can be as high as it wants to be, but if it's over 10, we definitely have to rule out cancer. Makes sense? The higher the PSA, the more likely it's likely to be cancer. Now, for complications, if urine doesn't flow, you're at risk for urinary tract infections. So you're going to get a bladder infection, and eventually you can get pyelonephritis as well. Now, don't forget, the bladder wants to contract and get the urine through that prostate, but the pressure builds up in the bladder. So the bladder gets thicker and thicker and thicker. And if you look at the wall, you'll see trabeculation. Do you remember I told you that's a $10 word for thick muscle? The bladder gets thicker. It gets trabeculated. And then the pressure builds up, so you start to get diverticuli. And that's not good because the urine can sit there. You get stasis. That's like a culture plate, the diverticuli of the bladder. Now, if the pressure builds up the ureter, you'll get hydroureter and eventually hydronephrosis and renal failure. Please don't let that happen. If a guy can't pee, help them pee. Don't wait until the pressure backs up and destroys their kidney. Guy can't pee, help him pee. Now, for treatment, in the old days, all they had was surgery, and it was barbaric. Have you heard of the TURP? Transurethral resection of prostate, the TURP procedure? You take a catheter with a biting forceps at the end. You take the penis, the urethra, you catheterize the urethra up into the prostatic area, and you go, it's like rotor. You make big holes, and that way urine can flow. It's bloody. It's barbaric. It's the last resort today. So if everything fails, we'll do TURP. What do we prefer to do? Drugs. Now, the classic drug here, there's two of them we should give. But the one they love to ask, what will actually shrink the gland? 5-alpha reductase inhibitor will shrink it. But how long will it take to shrink the gland down enough that you can pee on your own? This is going to take a year. Depending how big it is, at least a year to get a clinical effect. So you're going to have to be on this drug for at least 6 months, if not a year, to get clinical effect. Makes sense? So, John, I want to pee today. So what do we give with it? We give an alpha-1 receptor blocker, a Zosyn. Tyrosine, prazosin. We give a Zosyn because it relaxes the muscle. We relax the muscle, now I can pee. And what do the guys want? They just want to pee. They don't care about shrinking the gland. They just want to pee. Now, you're supposed to give them together. The alpha-1 receptor blocker, so I can pee today, and then the finasteride, so I can shrink my gland. I'll be able to pee on my own in the future. Now, the problem is, if you give finasteride, you're knocking out the major male hormone. So what does a guy get when you get on finasteride? You get male menopause. You get hot flashes. You get flushing. You get impotence. You lose your libido. For how long? A year? What do most guys do? They stop taking it. They just take the alpha-1 blocker because they can pee. I just want to pee. I still want to be able to do it. So you start both, and they usually stop the finasteride. They just stop it because the hot flash, the flushing, the impotence, they don't like it. So they usually stop it. Make sense? All right. Now, where do we see the nodules? Okay, BPH is nodular hyperplasia. So we'll see the nodules. They're in the central and transitional areas, the central areas next to the urethra. That's why they get obstruction. Now, if I tell you there's a nodule in the posterior peripheral zone, you're thinking cancer. Okay, this is more central and transitional areas. Makes sense. All right, now that brings us to prostate cancer. Very testable because it is one of the most common malignant tumors in men, and it's the second most common cancer death after lung cancer. Now, incidence increase with age, so the rule is if a guy lives long enough, they'll eventually get prostate. If you live to 200, every guy will get prostate cancer. So it's aging, we're eventually going to get it. Now, the highest rate and most aggressive tumors tend to occur in African Americans, so that's one of the patient populations we'll screen. We don't screen everybody. We screen people with family histories, some people at high risk, people with family history, and people that have African American ethnicity. Now, the problem with prostate cancer is a lot of cases are silent. So how can we screen for them? You'll have to do a digital rectal to feel something firm and a PSA to look for elevated PSA. Make sense? That's how to screen. If we don't screen, how will we pick it up? when it spreads to the lumbar vertebrae, you get back pain. So an older guy with back pain could be a herniated disc, could be osteoporosis, but it can also be metastatic prostate cancer to the lower lumbar vertebrae as well. So you just got to keep that in mind. When old guys get back pain, it's probably herniated disc, probably osteoporosis, but it could be cancer as well. Now, with very large local diseases, they can cause obstruction of the urethra. That's kind of rare because most of these tumors are in the posterior, peripheral area. But if they go to the central area, they can cause obstruction. Okay, now to diagnose it, I need tissue. So we're going to put a ultrasound probe into your rectum, and we will do transrectal biopsies. That's how we get to this. Remember, the posterior zone, right behind it, is the rectum. So we can biopsy the posterior area. Yeah, we do biopsies from both sides and different levels to evaluate the whole gland. Now, when this tumor spreads, where does it spread first? Well, your prostate's in your pelvis. So it goes to pelvic lymph nodes first. Pelvic lymph nodes are the obturator nodes and the iliac nodes. That's where it goes first. Where does it go next? Well, it goes from the pelvic nodes to the retroperitoneal periaortic nodes. Now, retroperitoneal periaortic is right in front of the vertebrae. So where does it go next? The lumbar vertebrae. So pelvic nodes, retroperitoneal nodes, then lumbar vertebrae. When it gets into the vertebrae, it activates the osteoblasts. So you're going to get an osteoblastic metastatic disease, bone forming. That's unique. Most tumors get in bone, they lyse it. They lyse it. Here, it forms bone. It turns on osteoblasts. So question, is an X-ray going to be very effective at seeing this? No, X-rays are better for lytic, right? So you have myeloma, lytic lesions, get an X-ray. We want bone scans here because osteoblastic activity lights up on a bone scan. So this is one of the times we want a bone scan to look for metastatic prostate cancer because it's osteoblastic, and blastic lesions light up like a Christmas tree on a bone scan. Now, another marker when it's in the bone is osteoblasts are going to release alk-Phos. That's another important marker. So if I ever say an old guy comes in with sky-high PSA, okay, could be BPH, could be cancer, and then I see elevated alkaline phosphatase as well, it's probably prostate cancer spreading into the bone. It's probably osteoblastic mets. Not good. All right, now treatment. We got to get the tumor out of the prostate. So we're going to do our prostatectomy. But John, what if you're old? You're an old guy. You're not going to survive the surgery. Okay, if I can't do surgery, then I will either externally beam radiate it or I'll implant little beads of radioactivity. That's called brachytherapy. But we need to treat the prostate tumor where it is. Okay, so again, either take the prostate out, or if you can't, you radiate it. Makes sense? Now, for metastatic disease, incurable. Once prostate cancer has spread, all you can do is palliate. You can only slow it down. So this, unfortunately, today, it's a death sentence. So when you see metastatic disease, we have to slow it down. Now, this is going to be hormone dependent initially. It needs the androgens. So how can I get rid of male androgens? Well, I can surgically castrate you. Ow! Or I can chemically castrate you. Which do you, well, they're equal. They both work great. I can surgically remove the testes, or I can give you drugs to knock out the testicular function. I think I'd prefer, I like those dudes. I think I'd like chemical castration. Now tell me, LHRH agonists can be used. How do you give them? Do you give them in a pulsatile fashion or a continuous fashion? Your pituitary responds to pulses. If you give it pulsatile, your pituitary will make more gonadotropins and your gonads will make more hormones and the tumor will grow. No, we want to shut it down. We're going to give it continuously. If we give it continuously, you'll shut off the pituitary, no more gonadotropins. Wee, 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 wee. Now your gonads don't work. You don't make androgens. The tumor stops growing. Make sense? Now, problem. The first time you give it, the pituitary thinks it's a pulse. It doesn't know it's going to be continuous. So when you first give it, you'll get a flare. You'll make LH, your testes will make androgens, and the tumor could grow. So what do we always give when we're going to give an LH-RH agonist to block the flare? We will give an androgen receptor blocker, like flutamide. Flutamide would be a great example of an androgen receptor blocker. Block the receptors because there will be a flare here. So let's block those receptors. So when I give leuprolide, we'll always give flutamide with it to block that flare. Oh, by the way, today we now have LHRH antagonists. So they knock this out without causing the flare. That's cool. So those drugs are they're new, they're kind of exciting because you don't have that flare that you have if you use an agonist in a continuous fashion. That's kind of cool. All right, now how do we follow prostate cancer to see are we winning or losing? We'll follow it with the PSA level. If it goes up, you're losing. If it goes down, you're winning. Now to see prostate cancer, it's hard to see it. It's easier to feel it. So it's kind of an ill-defined yellow lesion, usually in the posterior aspect of the peripheral zone. So peripheral zone nodule. And it's easier to feel it than it is to actually see it. They tend to be firm. Now we're going to grade this adenocarcinoma to see does it look like the prostate or is it just sheets of ugly tumor cells? We call it the Gleason grading system. Now remember, staging is still supreme. But in terms of grading, this is one of the most important of the grading systems. So I'm going to teach you how to do it. But really, as a clinician, you just need to know what it means. But let me teach you how to do it. Gleason grading system is what we do is we look at the tumor for the two most common patterns we see. We look for the two most common, and then we grade those patterns from 1 to 5. So we look at the first pattern, grade it 1 to 5. But then we look at the second pattern, grade it 1 to 5. Then we add those up to get the Gleason score. So what if the first pattern is kind of like in between? It's not great, it's not horrible, it's kind of like in the middle. You might call it a grade 3, that first area. The second area is just sheets. It's just not even trying to make glands. How would you grade that? Well, that would be poorly differentiated. That would be grade 5. Horrible. So grade 1 would look almost like a prostate gland, almost beautiful. Grade 5 is just sheets. So what would the Gleason score be in this patient? 3 plus 5 equals 8. Okay, so that's how we do it. We just look at the two most common patterns and we grade both of them. Then we add it up and that's the score. So what's the best it could be? The best it could be is a 1 and a 1, Gleason grade 2. The worst it could be is a 5 and a 5, 10. So a Gleason grade is from 2 to 10. All you need to know is the higher the number, the worse it is. So on your exam, it's always Gleason grade 8, 9, or 10. It's always 8, 9, or 10 because they want to ask about metastatic disease. They want to ask about the bad ones, okay? In terms of genetic mutations, there's only one mutation that you should know. It's right here. It's a fusion of 2 different genes, and this accounts for about 50% of all prostate cancers, so just keep it in mind. Now, in real life, there's only 2 kinds of prostate cancer. The low-grade one, that would never hurt you, and the high-grade one, the one that no matter what you do, it kills you anyway. It kills you anyway. So in my experience, there are 2 types of prostate cancers, the one that would never hurt you and the ones that are going to kill you no matter what. So if it's me, I'm never going to check. I'm never going to check. Because if I find a tumor, either it's going to kill me no matter what I do. Why have a prostatectomy and risk the risk of impotence, right? So for me, I'm just not going to check. But again, we're doctors. We always want to find things and diagnose things. But high-risk people should be screened. In the old days, we were screening everybody. We were finding a lot of low-grade tumors. We were doing so many prostatectomies and causing impotence for tumors that probably never would have did anything. So we were like causing morbidity and mortality over something that wouldn't have hurt us. Make sense? So that's why we only screen people that are at high risk. People that have prostate cancer history in the family, or people that are African American, somebody with a high risk, then we'll screen them because they're more likely to have the bad one. Okay? Makes sense. All right, prostate is like life. Hey, there's good life or bad life. No, all life is good. All life is. There's always something you can look at in your life that's good. But we, as humans, tend to focus on what's bad in our lives, right? So we think we're miserable. When somebody with like a terminal illness is like, I wish I was you, right? You hate your life. I wish I had your life. I know. Grass is always greener on the other side, right? All right, now let's go to the last PowerPoint that we have. Okay, we're doing really good here. We got the genital pathology done. Pretty straightforward, pretty good. Uh-oh, my TA is away from the thing. Let me see. Oh, no. The TA, Steve, is he's on point. He's on point. You're better than me, Steve. If I was watching this, I'd like fall asleep. If I'm not a doctor, I'd be like, this guy's entertaining, but I don't know what he's talking about. All right, now good news. Most of the time I teach this class, there's not enough time to do endocrine. We're getting endocrine. This is bonus material. Now, question, is endocrine high yield for physio? Woo, woo, woo. Negative feedback loops, up arrow down. Oh man, physio is salivating. Is it high yield for pathology? Just the tumors. The tumors. The pathology is the high yield. Now let's do it all. Let's do the physio again. Let's do the physio and the path. Let's do everything. Yeah, see, that's the problem. I've got the most material. If I want to integrate, I got the most material to cover, and they give me the same time as everybody else. So we're going to integrate because it's worth it. It's worth it to do things really well than to rush through things, cover everything, feel good. Oh, I covered everything, but I don't remember a damn thing. That's useless. So let's do this really well. Now, we're going to dedicate Chapter 25 to the amazing, brilliant, wonderful women in our lives. Why are we going to dedicate this chapter to women? Because the majority of endocrine lesions are more common in females. Men get them too, but it's much more. I'm going to get tired of saying more common in women than men. It's just the way of the world. So most of these diseases are more common in women. Now let's start with the thyroid gland first. We've got lots of endocrine organs to cover. Thyroid gland first. Now, goiter is a $10 word for a big thyroid gland. That's just a big gland. Now, when you have a big gland, I want to know, is it nodular or is it smooth and symmetrical? So that's what I want to know about a big gland. Here, we're going to feel lots of nodules. So we're going to call this a multinodular goiter. Goiter is enlargement, and it's got multiple nodules. Multinodular goiter. Now, another name for it is a non-toxic goiter. Non-toxic means you're not hyper. There's no hyperthyroidism. You're euthyroid. You're normal. Non-toxic goiter. So this is an enlarged gland, and if we look under the microscope, it's enlarged because the colloid follicles. You'll see lots and lots of enlarged follicles filled with colloid. So they call these colloid nodules. Now, who gets it? It's females, much more common than males, and it's usually asymptomatic because you're euthyroid. So if I ask you, what is the free T3 and T4? Normal. What is the TSH? They're all going to be normal because you're euthyroid in most cases. The only symptom is, Doc, what is this? I got a bumpy thing here. Yeah, you got this big old mass. That's the only symptom. Now, late in the course, one of those nodules can take over and you can get hyper. We give that a fancy name. We call it Plummer's syndrome, where late in the course you develop hyperthyroidism, you become toxic now, you become hyper. So we call this now a toxic multinodular goiter. Okay, so you can get hyperthyroidism rarely. Now, another way to get goiter is to have an iodine deficiency. That's going to be endemic goiter due to dietary deficiency of iodine. You'll see these big and large glands. Makes sense. We don't see that in the U.S. because we iodinize our salt. You're going to see this in Central Africa or maybe in the Himalayas where they don't have iodinized salt. But nowadays, every country is putting iodine in the salt, so this is becoming less and less common. Now, for the microscope, what do we see in most cases of goiter? You're going to see lots of colloid nodules. They got lots of colloid, these benign follicles, they're just enlarged. Now you'll see a lot of degenerative changes. They start to break down, so you get calcification, you get hemorrhage, you get cystification, you get fibrosis, but it's completely benign. Okay, so multinodular goiter, easy peasy. Now let's talk about hyperthyroidism versus hypothyroidism. Let's cover the difference. Okay, for hyper, it's pretty easy to identify it. Now, first of all, if you're hyper, everything's turned on. Your metabolism, you're going to burn calories, you're going to lose weight without trying. Your metabolism up. In fact, you're generally not heat, so you're always going to be hot. You're going to try to make things cold because you're like burning up. Now, what about sympathetic tone? Increased sympathetic. Everything's fight or flight. You're turned on. Your eyelids will be really raised because of the sympathetic tone. Fight or flight. Makes sense. So everything is turned on, and the reason for that is the free hormone. Free T3 and T4 are elevated. Makes sense. Now, clinically, everything's turned on. Your heart's turned on. You get tachycardia and palpitations. Do you know what arrhythmia is frequently associated with things like Graves' disease? AFib. They're turned on so much, you start getting AFib. So remember, hyperthyroidism and atrial fibrillation. The nervous system gets turned on. They get nervous, they get sweating, they can't stand the heat, they're burning up. They turn the air conditioner on all the time. The muscles get turned on, they start getting tremulous and very weak. And the GI tract, you get a lot of diarrhea. And of course, you're burning calories. You can eat all the food you want, you're going to lose weight like crazy. And what about the bones? The bones tend to start breaking down. There's an increased risk of osteoporosis as well. Very good. All right, now question. If you're hyper, it's pretty obvious, right? We see these symptoms. We know that T3 and T4 elevate. We know that. So what do we want to find out? Why? Why are you hyper? Is it the thyroid that's causing it? Is the pituitary or is the hypothalamus? So let's draw this little diagram. Hypothalamus is the master controller. It's going to control your pituitary, right? Controls the pituitary. And then the pituitary is going to make TSH, and that is going to stimulate the gland. So here's my thyroid gland. So if you are hyper, clearly the gland is making too much hormone. T3, T4 are sky high. You're hyper. So now I want to know why. Is it primary? Is it the thyroid? Is it secondary? Is the pituitary? Or is it tertiary? It's the hypothalamus. Who is causing this? Well, the quickest way to tell them apart is the TSH level. So whenever you see hyper, your number one test is TSH to determine the etiology. Now, if the TSH is decreased, what does that mean? Well, that means nobody's telling the gland to work. The gland is working on its own. The gland is doing it itself. So now we know it's a primary hyperthyroidism. The most common primary cause of it, it's Graves. Circle Graves immediately. So if the TSH is low, it's going to be hyper due to the gland. It's going to be Graves' disease. Now, vice versa. What if the TSH is sky high? Well, if the TSH is sky high, it's being told, the gland is being told, work, work, work. You can work from home, work, work, work. You got to work. So it's not the gland's fault. It's the pituitary or hypothalamus. So if TSH is elevated, you need to do imaging of the sella turcica and hypothalamic area to look for tumors. Make sense? So secondary and tertiary are going to be picked up by imaging. You do imaging. Make sense? All right, now let's go back to primary. If the TSH is down, we know it's the gland that's doing it. So we got to think about Graves' disease, a board favorite. They love Graves, very high yield. Now, this is an autoimmune disease where you're making autoantibodies against the TSH receptor. Now, remind me, what type of hypersensitivity is that? I know the target's not just the thyroid, it's the TSH receptor. I know the exact. That's a type 2, but be more specific. Does it destroy the gland or does it stimulate the gland? This is a non-cytotoxic type 2 reaction. Most type 2 destroy. This is a non-cytotoxic type 2. It stimulates. In fact, what's the name of this antibody? Well, the old name was long-acting thyroid stimulating antibody. LATS, long-acting. It's in the margin. If you look in the margin, the old name is long-acting thyroid stimulating. What's the new name? Thyroid stimulating immunoglobulin. Much easier to remember. Thyroid stimulant immunoglobulin. So this is the immunoglobulin that's going to stimulate the gland. This is why you're going to get a goiter, but it's going to be diffuse and symmetrical. It's not going to be nodular. It's going to be diffusely enlarged. Makes sense? And it's turned on. It's turned on. You're going to get hyper because of these antibodies. Now, who gets autoimmune diseases? Females more than males in their reproductive ages. Now, clinically, we're looking for a triad. The first part of the triad is a diffuse symmetrical goiter with hyperthyroidism. That's number one. A big gland that's on. Oh, by the way, how do I know the gland's on? Iodine uptake scans. Have you heard of the radioactive iodine uptake scans? You're going to give radioactive iodine to see is the thyroid picking it up? Is the thyroid gland on? What are you going to see in Graves? You're going to see diffuse, symmetrical, increased uptake. Compared to normal, this gland is super on. Diffuse, symmetrical, lighting up. The whole thing is lighting up really dark. It's lighting up. So diffuse, symmetrical, lighting up like crazy because it's sucking up the iodine like crazy and making hormones. Okay, so that's all the uptake to say. The uptake test only tells me one thing. Is the gland on or is the gland off? If the uptake is increased, that gland is on. If the uptake is decreased, that gland is off. Like in hypothyroidism, gland would be off. Makes sense. All right, so this is the key. 3 things. Number 1, we look for the big, diffusely enlarged symmetrical goiter with hyperthyroidism. Number 2, these antibodies don't just stimulate the thyroid. They stimulate the fibroblasts to lay down glycosaminoglycans, juicy tissue. So you get what's called myxedema, where you get it behind the eye. So all this glycosaminoglycan connective tissue pushes the eyeballs forward. And the sympathetic tone, the eyelids are really high. So it looks like a deer in a headlight. You get these bulging eyeballs. Yeah, you look like goiter. Not goiter, the exophthalmos. They call it proptosis, exophthalmos. So that's what we're looking for, these bulging eyeballs. And then number 3, the fibroblasts get activated in front of the tibia. They lay down myxedema, so you get pre-tibial myxedema. Again, if you feel your tibia, you feel bone. It's firm. You should feel it. You won't be able to. It'll feel doughy. It'll feel squishy, because you have all this juicy connective tissue there. So this is our classic triad. A symmetrically enlarged gland that is on hyperthyroidism with exophthalmos and pretibial myxedema. Do you have to have all 3? No, but usually you do. Make sense? Okay. All right, now for the microscope, what would the gland look like? Well, it's on. So you will see the colloid being slurped up. The colloid's being absorbed. So let's start at the beginning. Okay, here's a normal thyroid follicle. It's lined by follicle cells. Follicle cells, these are all the cells, follicle cells. And in the center, you should see colloid. It should be filled with pink colloid. Okay, now when you get hyper, these cells get bigger and they proliferate. So the gland starts to enlarge, and you'll see it's kind of like infolding now. You'll see these cells are growing up and in and up and in. It's kind of infolded because there's more cells now. These follicle cells are proliferating. Okay, so increased number of cells. They're bigger. They're growing upwards. Now, when you look at the colloid, there's less colloid. There's less because it's being reabsorbed and secreted. In fact, if you look at the edges, you'll see a bubble and another bubble, another bubble. You'll see these bubbles at the edges. Those are called resorption vacuoles. You're reabsorbing the colloid and releasing it. So you'll see bubbles. So what do they say the edge of the colloid looks like? Well, if I draw it over here, bloop, 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 bloop. So the colloid's here in the middle, and the edges have these bubbles. They say it's like a scalloped appearance. It's like a scalloping of the colloid. So again, here's the follicle cells are out here, and the colloid is in the middle, and you see these bubbles at the edges. They call it a scalloping of the colloid. Whenever you hear a scalloping or bubbling of that's hyper, because you're reabsorbing it and releasing it. Okay? All right, now, are there any other causes of primary hyperthyroidism? Well, Graves is it. Graves is the biggie by far. But there are some other causes. Do you remember we talked about multinodular goiter? Late in the course, you could get Plummer's syndrome, where one nodule takes over. You can get hyper from that. You can also get hyper from an adenoma. Now, most adenomas are cold. They're non-functional. But every once in a while, you'll get an adenoma that makes you hyper. So they call it a toxic adenoma. What else? Hashimoto's thyroiditis and subacute thyroiditis can give you a transient increase in hyperthyroid. Why? Because the inflammation. The follicles will leak the colloid. During the inflammatory process, that will leak it, so you'll get a transient hyperthyroidism. In fact, in Hashimoto's, they call it a hashitoxicosis. They get toxic for a little while, then they destroy the gland, and they go hypo. They're hypo the rest of their lives. But there'll be a few months where they're hyper because the inflammation. Leak out, you get a transient hyperthyroidism. Okay, now that we did hyper really, really well, let's do hypo. Hypo means everything's slowing down, right? Hypo. So the metabolic rate is down, the sympathetic tone is down, you're going to gain weight like crazy because you're not burning calories. You're going to be cold all the time. Everything's slowing down because you have low levels of hormone. Now, clinically, it's the exact opposite. You have no energy. You're exhausted. You're fatigued. You're lethargic. You want to sleep. What else? They're very sensitive to cold. Yeah, cold. I think all women have mild hypothyroidism. Right, gentlemen? Because she always gets cold before us, right? She's always, I know. Either they have hypothyroidism or they're just checking to see if we're a good guy. I'm cold. Is he going to put his arm around me? Is he going to offer me his jacket? So I'm not sure which it is. Maybe it's both. All I know is I diagnosed my mom. I came up from college, and I was like, Mom, it's like a sauna in here. I'm sweating. She's like, no, I'm cold. I'm like, Mom, this thermostat, it's 90 degrees in our house. It is a sauna here. She's like, I'm cold. Leave it. Don't touch it. You have hypothyroidism. You're hypo. I'm going back to, I went back to college. She called me 2 weeks later. You're right. I went to the doctor. Not only did I have hypothyroidism, I'm turning Japanese. I was like, what do you mean? That might be cool. Japanese are cool. What do you mean? She goes, I got Hashimoto. You're not turning Japanese. That's just a common cause of hypothyroidism. It's a thyroiditis. You're not turning Japanese. You just need to take replacement hormone. You need to take your Synthroid. Yeah, she thought she was turning Japanese. See, for you and me, these things don't sound bad, right? They don't sound bad. You're like, oh, it's Hashimoto's? No big deal. It's hypothyroidism. Take your Synthroid. You'll be fine, right? The rest of the world is like, I have Quasimodo? What do I have? They go home, Google, I'm going to get a hump and Quasimodo. Oh, man. This is why spend a little bit more time explaining things to patients and you become legendary. You become legendary because you and me, it's not a big deal. These words we're used to. The rest of the world here, these big words, they think they're dying, right? So spend a few minutes, explain what it means. In fact, if you're ever going to diagnose something, you say, can you write this down, please? Can you write this down? Because if you just listen, you're going to mishear me. Can you write this down? Do you have any relatives here? Can you bring them in? You want to bring them in? So you have 2 ears. 2 ears are better than, 2 people listening, better than one. Because I made the mistake as a resident. I just said, oh, you got Hashimoto's, take your Synthroid, you're fine. The next week, I got calls from all the family members. My grandma's dying? What? She's going to get a hump? What? No, it's Hashimoto. It's thyroid. It was horrendous. So please explain things to your patients. I know we're doctors. We don't have a lot of time, but you can be legendary. And another thing that makes you legendary is if you pick up your phone. When the patient calls, if you actually will pick up, legendary. Because try getting in touch with your doctor. It's like impossible. You can barely get a nurse. But for like serious things, pick up the phone. If you pick up the phone, you're at the club, at the country club. Oh, this weekend, I talked to my doctor. Yes, my doctor called me. I talked to them. Does your doctor doesn't call you? Your doctor, you need my doctor. You will never have a problem getting patients. You'll have to turn patients away. You'll be legendary. That makes sense? Can you tell me what's the number one cause of lawsuits? not connecting with the patient. If the patient doesn't feel connected to you, they sue you. They sue you when something goes wrong. If they feel connected to you, you never get sued because they realize you're on their side. You care about them. Make sense? But John, I only have 10 minutes to see each patient. How can I make a kit? I know. And the worst thing ever was electronic medical records. They require you to do electronic, but it's the worst thing in the world. So instead of talking to the patient, you're saying, okay, what brings you in today? Uh-huh. Do you have any fever? You're not even looking at me. So I forbid my students to use the electronic medical record initially. They have to go in there with a pen and paper. Because with a pen and paper, I can look in the eye, write something down, look in the eye, write something down, right? Then you can go enter it later into the electronic medical record. I want you to connect with your patients. If they feel like you care, number one, placebo effect. Number two, you'll have better outcomes. And number three, they'll care about you and you'll never get sued. Make sense? They care, you care about them, they care about you. And that's what people care. People want doctors who care about them. Because nowadays, ask your friends. They don't like their doctors much anymore. Because they just go in, I get the nurse, I don't even get the doctor. Yes, it's break time. Go on your break. I'm just having fun. All right, 10 minutes. I'll see you guys in 10. We'll keep going on the endocrine. Again, this is all bonus. I don't usually get this far, so this is great stuff. All right, see you in a little bit. right, my warriors. So far, so good. Rocking and roll through this material. We did hyper, and we're doing hypo now. Now, the symptoms we were starting to talk about is everything slows down, right? You get fatigue, you get very sensitive to cold, you want to surround yourself with hotties. Your heart decreases the output. This is why they're so fatigued. They have no cardiac output, really low. They start getting myxedema, just like you do in hyper, but they get in different areas. They don't get it behind the eye. They don't get into tibia. They get it in the hands, big doughy hands, the feet, the tongue. They get macroglossia, deep voice. So they're getting this myxedema, but in different areas, mostly the face, the hands, the feet, the throat, the tongue. Now the GI tract will slow down. They get very constipated, and they often have loss or anovulatory cycles because everything slows down here. Now again, we know that the gland is not making the hormones. So we want to know why. What is the etiology? If the gland is not making hormones, why isn't it working? Why? Well, we got to check the TSH. That's the key to see, is it primary, is it secondary, or is it tertiary? That's what we want to check. Okay, so we'll check the TSH. If the TSH is sky high, think about what that means. That means the pituitary is saying, work, work, work. Come on, you can work from home. And the gland says, nope, I don't want to. That is a primary issue. Something is wrong with the gland. Always think Hashimoto's first. Hashimoto's thyroiditis is the most common non-iatrogenic cause of hypothyroidism. Okay, so always think about Hashimoto's. Graves for hyper, primary. Primary hypo, think about Hashimoto's. There's other causes too. We'll talk about them all. Don't worry. Now let's do the opposite. What if TSH is really low? Well, if TSH is low, that's why the gland's not working. It's taking the day off because no one's telling it to do work. So now I need imaging of the sella turcica and hypothalamic area to look for, see is it secondary or tertiary. Make sense? So this TSH is our key test for distinguishing the etiology. Knowing it's hypo, that's easy. Look at the symptoms, look at the T3 and T4 level. But to tell the etiology, we need TSH. Now, for primary cases, in real life, the most common cause of primary hyperthyroidism is actually doctors. We destroy the gland all the time on purpose. We will either do a thyroidectomy for cancer or other reasons, or we will ablate it with radioactive iodine. But again, this is not an issue. We know we destroyed your gland. We're going to give you synthetic hormone replacement. So it's not a diagnostic issue. So excluding doctors, the most common cause is Hashimoto's. If you remove non-iatrogenic. Now, before I talk about thyroiditis, I just want to mention again congenital hypothyroidism. People call this cretinism, Christ-like. And this is common in endemic areas where they have iodine deficiency. So it's not as common as it used to be. And it's going to be more away from the sea because sea salt has iodine. So it's like Central Africa away from the coast, or maybe up in the Himalayas, very far from sea level. That's where we'll see iodine deficiency, either in utero or during early life. So without thyroid hormone, you're not going to grow. So these babies fail to thrive. They're going to be stunted growth. They're going to have dwarfism. They're going to have short stature. They're also going to have a lack of development of the brain. You need to have thyroid hormone to develop brain. So they're going to get spasticity, incoordination, and severe intellectual disability. That's why they call them cretins, Christ-like. They are so intellectually disabled, they can't think evil. They can't have evil thoughts. They're like Christ. They can't think evil. So that's why they call them cretins. Okay? So not good. Your brain doesn't develop. Your bones don't develop. You fail to grow. We really need thyroid hormone for development. Now, what if you're perfect and then you move to an area that doesn't have iodine in the salt and you get an iodine deficiency? Well, my brain is developed already. My bones are already developed. So what am I going to get? I'm just going to get a goiter. I'm going to get a goiter because the gland is trying to make me hormone to keep me euthyroid. So it gets bigger and bigger because there's a deficiency of iodine. It just tries to work harder. So they get this incredible goiter. Now, my friend is a surgeon in Nigeria. If you ever get to meet somebody from Nigeria, They're some of the nicest people in the world. Great heart, good people. He said, man, we get these crazy cases, though. We get these cases. Send me pictures of these women coming in with these ginormous masses, these huge goiters. So we never see something like that in the U.S., but you can see it in areas where they don't have iodine. Okay. All right. Now, what about thyroiditis, Barone? You said Hashimoto's. That's what your mom got. Yep. This is the most common non-iatrogenic cause of hypoprimary thyroidism. All right. Now, it's an autoimmune destruction of your gland. So you're destroying it. That's why you're going to wind up with hypothyroidism. So you're going to wind up with. It's the most common non-iatrogenic. So if you exclude doctors doing thyroidectomies and radioablation, this is the most common cause of hypothyroidism in the U.S. Now, who's going to get it? Well, women, because it's autoimmune, usually in the later reproductive years. Yeah, my mom was in her 50s when she got this. Now, since you get hypothyroidism, first, though, they get a few months of hyper. So if I'm going to draw the thyroid function over time, you start out euthyroid. When you first get inflammation, the gland leaks hormone. So you go hyper for a few months. They call it a hashitoxicosis. I was like, Mom, did you get hyper for a while? She goes, yeah. For a few months, it was beautiful. I was staying up all night. I was getting work done. I was pooping like a fiend. I was losing weight without trying. People love being hyper. They love it. People don't complain when they're hyper. They're getting things done. They're losing weight. Now, they will get some palpitations. That's a problem. They can have some bone loss, but they don't usually complain. So for a few months, she was staying up all night, and then they destroy the gland, and they go hypo for the rest of their lives. They're going to need Synthroid. And that's when they come in. They come in when they're hypo. And that's Mom. She was cold all the time. House like sauna. She was gaining weight. She wasn't pooping. She was constipated. And she was like, I can't think. I can't think. Yeah, the brain, it's like a fog. They call it myxedema coma. You have trouble thinking. Everything slows down, even your thoughts. So that's the problem. That's when they complain, when they're hypo. So initially, there might be some hyper, but then they go hypo. Now, what did I tell you about autoimmune diseases? Once you attack yourself one way, what could happen in the future? I have to watch my mom for other autoimmune diseases. So they can get things like lupus, they can get rheumatoid, they can get Sjogren's. You have to watch for other autoimmune diseases. Now, another problem is if the immune system goes crazy, you can get lymphoma. There's an increased risk of lymphoma. Now, make me proud. Make me feel like you've learned something from me. Inflammation, lymphoma. Which lymphoma do we pick when there's been inflammation and then you get a lymphoma there? Do you remember like H. pylori gastritis? You'll get what's called a multoma. Multoma. But is this a mucosa? No, this is not a mucosa. So you can call it a multoma, but in mucosis, we call it that. This is going to be called a B-cell marginal zone. Marginal zone lymphoma. Okay. You can call it multoma. That works too. Same thing. Just it's not a mucosa, so you preferred to call it marginal zone. All right. Now, what is the gland going to look like? Well, it's inflamed and there's no colloid. So have you ever seen a thyroid gland? They're dark red. They're juicy. They look like dark red meat because the colloid. When there's no more colloid, it looks pale. So the gland is really pale. It's inflamed. There's no colloid. It's pale and it's enlarged. Painless enlargement of the gland. Now tell me, gland is enlarged. So should I see is it on or off? Yeah, what would I see in an iodine uptake scan? Symmetrical, decreased uptake. It's like not lighting up at all. Like just a couple areas, barely. I mean, it's off. So symmetrical, decreased uptake, that's hypo. It's not working at all. Now for the microscope, what's killing the gland? Lymphocytes. This is a T cell problem. T cells are coming in and they're killing the gland. That's why initially you get hyper because you kill the follicle cells, the colloid's going to start leaking out. Makes sense. You'll see a lot of inflammation. You'll often see germinal centers. So you'll see germinal centers, some B cells, T cells, and when you damage the follicle cells, they get big and pink. We call it Hürthle cell change. So I just remember Hürthle cell, Hashimoto, Hürthle cell, Hashimoto. Those are damaged follicle cells. They're being injured. Now remind me, can other things injure follicle cells and get Hürthle change? Yeah. So it's not 100%, but it's certainly something that they could ask about. So lymphocytic inflammation coming in to destroy the gland with some Hürthle cell change of the follicle cells. That's the classic feature. Now, I got to be honest. We don't biopsy the gland anymore. In the old days, they used to take it out or biopsy to see what's wrong. We used to see this. Not anymore. How do we diagnose autoimmune attacks? We look in the blood for autoantibodies. So they diagnosed my mom by looking for thyroid peroxidase antibodies. Thyroid peroxidase antibodies, that's how we're going to diagnose it. Now, thyroid peroxidase is inside the microsome. So the old name for this is antimicrosomal antibodies. Microsomal. Sometimes they'll use this old name. So let's repeat. How to diagnose my mom? They didn't biopsy it. She was hypo. Most common hypothyroidism is going to be Hashimoto's. They checked her bloodstream. She had thyroid peroxidase antibodies, and they made the diagnosis. Now, they also get antibodies not just against the microsomal thyroid peroxidase, but they also get them against thyroglobulin. So I'll just put that here as well. Thyroglobulin autoantibodies. Ulin. Oh, geez, it's so hard to write with this thing. Thyroglobulin. So again, that's how we diagnose. We look for the antibodies. Okay, now this is the most common thyroiditis, but there's some other ones they could ask about as well. Do you remember subacute thyroiditis? It comes on subacutely. So it's acute, but not super acute. So subacute thyroiditis. It's also known as de Quervain. I love that name. De Quervain rhymes with pain. This is the first one that's an enlarged tender gland. All the other ones were enlarged, but they didn't hurt. This one's tender, especially when you swallow. When you swallow, it's going to hurt because you move it. You move it. So that's when they're going to detect it. They're going to say, Doc, when I swallow, it hurts. And then I felt this enlarged gland. I feel something here. Yeah, that's de Quervain, subacute, tender thyroid gland. Now, we don't remove them, but if you did, it's granulomatous inflammation. You don't see granulomas in the thyroid gland very frequently. That's pretty cool. It's granulomatous inflammation. And it's the second most common type of thyroiditis. It's going to be more in females than males, but what's triggering it? A virus. Because of the virus, you get inflammation. The gland enlarges, becomes tender, but guess what? When viruses go away, the inflammation goes away, you go back to normal. So this usually is self-limited. Usually in 2 to 6 weeks, they'll be back to normal. Okay, so you have a couple of weeks of enlarged tender gland, and then usually a month or so, it's gone. It's gone, like a virus. It comes on its own, goes on its own. So we're looking for a tender, enlarged thyroid gland. Now, what happens to the function? Well, your euthyroid, when it gets inflamed, you go hyper, and then you go back to normal. You go back, you don't get hypo here. You don't destroy the gland. So you get hyper for a few weeks, and then you go back to euthyroid. That's great. So this is a good one. In fact, most cases, you diagnose it clinically. Woman comes in with pain when they swallow. They have an enlarged gland that's tender. Sounds like de Quervain's. I'll see you back in 6 weeks. It's better? Great. We're done. Make sense? All right. Now, the last one's also kind of rare, but they like it. This is called Riddell's fibrosing thyroiditis. So we get inflammation leading to fibrosis. It's kind of a rare disease, and you destroy the gland by dense fibrosis. And if fibrosis, not just the gland, but the structures of the neck, so it also fibroses the trachea and esophagus, so it kind of strangles you. So what cancer of the thyroid also strangles you? Anaplastic carcinoma of the thyroid. It mimics anaplastic carcinoma, which strangles you to death. So these patients have trouble breathing, they have trouble swallowing because it's wrapping around, the fibrosis wraps around. Now, how would I tell them apart? Anaplastic carcinoma versus just fibrosis. Well, the age is important. Anaplastic carcinoma is usually over 60. This one's more middle age, more 40 to 60. So they're kind of younger for this, older for this. But ultimately, you need a biopsy. You need a biopsy to distinguish for certain, right? Is it anaplastic tumor or is it just fibrosis? So we're going to need a biopsy here. Now, what are you going to do for this? Well, at biopsy, I see it's fibrosis. Fibrosis is destroying the gland and the surrounding tissues. What am I going to do? Resect the gland? No. When you have fibrosis, you're destroying the planes. You can't find the anatomic planes. So you're going to cut the jugular if you just go in there and rent like a cowboy. So you can't resect this gland. What we do is we resect the isthmus. Do you remember the thyroid's like this? We resect the isthmus to open it up. If you just take out the isthmus, you're away from the jugulars and the carotids. So remove the isthmus, it opens it up, and they can breathe better, they can swallow better, and they feel a lot better. Make sense? All right, now one more thing you need to know about Ridell's. This is often associated with the IgG4 related diseases. Do you remember that? IgG4? So they have these plasma cells in autoimmune syndrome where the plasma cells make high levels of IgG4. They get Ridell's fibrosing thyroiditis. They get fibrosis of the retroperitoneum and mediastinum. They often have autoimmune pancreatitis. And they can have glomerular diseases too. There's a whole bunch of things that are together with this weird autoimmune syndrome. Again, prednisone can kind of slow it down a little bit. All right, now let's talk about tumors. Finally, some pathology here. Let's do some tumors. Now, here's a tumor-like condition. A young kid comes in, and you see a cystic lesion right in the midline. Now, you take some gauze, you grab the tongue, you pull it. You pull the tongue, goes up. It moves with the tongue. That is called a thyroglossal duct cyst. Remember, the thyroid starts at the base of the tongue, then it migrates down. So if a piece of that tract is left behind, it could become a cyst. And it's usually right by the hyoid bone. It's usually above or below the hyoid bone. So we're going to resect it. It's benign. We'll resect the cyst with the middle of the hyoid bone. If you don't take the hyoid bone, it usually recurs. So make sure you take out the cyst with the mid portion of the hyoid bone. So the key is location. Midline neck mass in a young child or young adult. You pull the tongue, it moves up because it's part of the thyroglossal duct. That's remnant became a cyst, and it's usually lined by squamous or respiratory mucosa and surrounded by thyroid tissue. If it becomes infected, it can get very tender, but we just remove it, we're cured. Now I have a question. What would you change your answer to if the cyst was lateral on the sternocleidoid mastoid muscle? What would you call that lateral neck cyst? That's a brachial cleft cyst. Very good. Very good. So the location is key for these neck cysts. Okay, you got to know where it is. Okay, now in terms of tumors, you can have adenomas and you can have carcinomas. Which are more common in real life? Adenomas by far. Which are most tested on exams? The carcinomas. Even though carcinomas are nowhere near as common, they love the carcinomas. So adenomas are more common. They just don't ask it a lot. Now, there's different types of adenomas, but follicular adenomas are the most common. Now, here's the rule. Most benign and malignant tumors are non-functional. So if I did an iodine uptake scan, they would be cold. Cold. That's what we work up, cold nodules. So here's my thyroid gland. It's all on. It's all on except this one area. So it's all lighting up normally, but this one area isn't. That's a cold nodule. That's something we have to do a biopsy of and see what it is, okay? Because it's more likely to be either benign or malignant tumor, okay? So we got to work up cold nodules. Now, every once in a while, these could be toxic. If they're toxic, they'll be hyper, so they'll light up even better. You'll see that area lighting up like crazy, but that's kind of rare. It can cause hyperthyroidism, but that's kind of rare. Most adenomas and carcinomas are cold on uptake. Now, if you take a look at this picture, here's the capsule. Here's the capsule of the adenoma. These are the tumor cells. Notice they're trying to make follicles. Do you see the little colloid in the middle? They're trying to make follicles. See, this is well behaved. This is a benign adenoma. It's a follicular adenoma. It's making follicles. Now, over here is the normal thyroid. Notice it's a little compressed by the tumor, but here's what they should look like. Okay? So it's trying to behave. So this is what a follicular adenoma looks like. Now, my question is, well, how do I tell the difference between a follicular adenoma and a follicular carcinoma? They both make follicles and colloid. The capsule. If the capsule is intact, it's benign. If the tumor invades the capsule, either into it or through it, then it's a follicular carcinoma. It's all about the capsule. And the surgeons get mad at me. They get mad at me because there's a cold nodule, so they stick a needle in, they suck out, they aspirate some cells, and they send it to me. Now, under the microscope, when you aspirate this, I'm going to see follicle cells and colloid. And I'm going to say, follicular neoplasia. And they're going to call me, Barone, is it an adenoma benign or is it a carcinoma malignant? Which is it? And I'm going to say, I don't know. Take it out so I can see the capsule. I can't tell them apart without the capsule. Does that make sense? They get mad at me, but see, if they stick a needle in, they suck it out, and they see orphan Annie nuclei, I could say it's papillary carcinoma. It's a diagnosis of nuclear features. I could say papillary carcinoma, but follicular, I can't tell benign from malignant without the capsule. Makes sense? I know. Don't worry, I've trained my surgeons. I've trained them. They know exactly what to do. When I say follicular neoplasm, they know they have to take it out to see the capsule. Very good. All right, now for the carcinomas. The carcinomas, the most common is the papillary, and they love to test it, and you're going to see it. Your friends are going to get this. Not you, you're perfect. But this is a tumor of our age group. Now, it's 80% of all malignant thyroid tumors and affects females more than males, and it's our age group, 20s, 30s, 40s. So one of your friends may get it. Now, of course, if they go to Nagasaki, Hiroshima, Fukushima, Chernobyl, if there's a radiation exposure, that increases the risk. But a lot of cases, there's no radiation exposure. So if there's radiation, it increases the risk, but there's not always a history of it. Now, the good news about these is they're malignant, but they're very curable. Very curable. Because number one, I can remove your thyroid gland with the cervical nodes, because it spreads to cervical nodes. But what if it spread beyond? I'll give you radioactive iodine wherever the tumor is. It'll pick up the radiation and die. So these are highly curable tumors. Check it out. Excellent prognosis. The 5-year survival? No. Everybody's alive. We use the 20-year survival. 90% are still alive in 20 years. That's amazing. That's amazing. So these are very curable tumors. So you're going to see them in your age group, and they're usually curable, which is wonderful. Now, when they do spread, they spread to cervical nodes, so we'll take those out with the thyroidectomy. Now, in terms of mutations, there are 2 mutations. We have a fusion of the RET oncogene with the papillary thyroid carcinoma gene. What did you say? A fusion of RET with the papillary thyroid carcinoma. Do you think they're going to ask about it when the name is papillary thyroid carcinoma gene? No. They're going to ask the other gene. The other gene that's been associated with these tumors is BRAF. BRAF V600E activating mutations. So these are the 2 classic mutations. They can have one or the other. This is the one they're more likely to ask about because the other one has the name, papillary thyroid carcinoma gene. Too easy. Now for the microscope, what's cool about papillary tumors? Well, they have papillary structures. That's cool. They have calcifications like layers, soma bodies. But these are not diagnostic. They're not diagnostic. They're great clues, not diagnostic. What's diagnostic are the nuclear features. Here's what you're going to see. In the nucleus, it's empty. The chromatin is dispersed. It looks empty. You don't see the chromatin. It looks empty, like empty eyes of the cartoon character. If you go to Google, type in Little Orphan Annie comic from the 30s and 40s, you will see her eyes were empty. They didn't put a pupil in. Now, when you look at it, if I was a kid, I would freak out. She looks like a zombie.
She looks soulless, without a pupil. And her dog had the same eyes. He looked like a demon dog. So I don't know about you, but if I was a kid, I would have been scared. I would have been scared of that comic. Everybody else in the comic had pupils except for the lead character, Orphan Annie, and our dog. Looks scary. So same thing here. It looked like there's nothing in there. It looks like little Orphan Annie. They're clear. Or they can have grooves. So they're clear with a groove. Or they can have these cytoplasmic little inclusions. So intranuclear cytoplasmic inclusions. These are the cool features that are diagnostic. I don't need to have small bodies. I don't need to be in papillary structures. As long as I see those clear nuclei, like Orphan Annie, we can make the diagnosis. It's all about optically clear. And what's really cool for me is I had the privilege of being a resident with one of the my attendings describe this. There were two authors that described it. I work with one of the two who described the little Orphan Annie nuclei of papillary. Yeah, it was so cool. I was like, oh my gosh, you described it? I'm not worthy. I'm not worthy. I mean, wow. When you work with great lists, pretty cool. And at Cedars-Sinai, we also had the guys who invented the famous catheter. Oh, geez, I can't. It's escaping my name now. I'm under pressure, but it's just so cool to be associated with people who've described things that everyone talks about medicine. It's like, wow, it's cool, right? All right, so remember these nuclei. They're classic for the exam. They love these clear nuclei. All right, now the other carcinomas are lower yield. Now for follicular, there's only really two things you need to know. Okay, number one, follicular. It's a malignant tumor. It's got follicles, but how does it spread? Hematogenously. So this is the only one that doesn't go to the notes. It goes to your lungs. Always check the lungs for follicular. It's an exception to the rule. It likes to go hematogenously. The other thing that's important is, how do I tell it from benign? Invasion of the capsule. So it invades the capsule or the veins. If it invades the blood vessels, it's malignant. So you're looking for this invasion. When you see it, then you call it a carcinoma. Now, much more likely, 5 stars would be medullary carcinoma. But John, it's only 5% of malignancies. Yeah, but it's 5 stars. It's 5 stars because they can ask, what cell does it come from? It doesn't come from follicles. It comes from the parafollicular C cells. What are they supposed to make? Calcitonin. So you're going to see really high levels of calcitonin in the blood. And this is going to make the calcium level drop. Okay, now let me ask you, it makes calcitonin as procalcitonin, which makes beta-pleated sheets. So what must I see around these tumor cells? I must see an amyloid stroma made of procalcitonin. So I can't make this diagnosis until I do the Congo red. I need to see the amyloid stroma. Okay, so I see the nuclear features for papillary. I need amyloid stroma for medullary. Now, 25% of these patients are going to have MEN syndrome, either 2A or 2B. They don't call it 3 anymore. They call it 2A or 2B. Okay, so look for the RET mutation. RET. See why this is high yield? They can ask about parafollicular C cell. They can ask about calcitonin. They can ask about amyloid. They can ask about MEN association and PHEOs, because they get pheochromas with MEN 2A and 2B. They can ask about RET. All these things are testable. All right, now the last one is lower yield, but it's the most evil tumor I've ever seen. Why is this evil? Because in my practice, I've never seen anybody survive it. People do survive it, but I've never seen it. This is an evil tumor. It kills you really fast. Now, it's more common in females, but look at the age. They're almost always over 60. They're older people. Okay, so if you're going to have a really bad tumor, get it when you're old. Don't get it when you're young. So this occurs in old. Now, they always present the same way. This mass, this bulky mass, it strangles them. They literally get strangled by it. So they get shortness of breath, they get stridor, they get trouble swallowing. It wraps on the trachea, the esophagus, the vessels. Now, question, can I resect your carotids, your jugular, your... I can't resect this. It's wrapped around all these things I can't resect. And it spreads very early. So you can't cure it anyway. So this is an evil tumor. So what do? Well, we'll do a biopsy to confirm it. We'll see
Well, what do you think you're going to see in an anaplastic carcinoma? You're going to see undifferentiated anaplastic tumor cells, lots of mitosis. They'll have P53 mutations, mitotic figures, Ki67 is elevated. Everything you know is bad. These are really bad tumors. Here's what you do. Since most patients are not going to be curable, you're going to palliate. You'll put a hole here so they can breathe. You'll put a hole in their stomach so you can feed them. And then you say, bucket list time. Leave today. Don't wait a week. Leave today, because the average survival for this is only about a month and a half. A month and a half. Terrible. I don't wish it on my worst enemy. That's a terrible tumor. Okay? So it's anaplastic. It kills you quickly. All right. Now that the thyroid's done, let's talk about some parathyroid. Now, how many parathyroid glands are there? Well, there are 2 that are superior, and there are 2 that are inferior. Do you remember the inferior ones come from the 3rd pharyngeal pouch? And then the 4th pouch is going to give us the 2 superior ones. Remember that embryologically? There are 4 parathyroid glands. Very good. Okay, now let's talk about primary. It means it's the glands doing it. Hyperparathyroidism means too much PTH. So let's do the physio first. Let's do physio first. Okay, if there's too much PTH and the gland is making it, okay, what's going to happen to the calcium level? The gland is making too much PTH. You're going to get hypercalcemia. You're going to get kidney stones. You're going to get metastatic calcifications. Makes sense. What happens to the phosphate level when you have phosphate trashing hormone? I mean PTH. Phosphate is going to get trashed. Okay, does that make sense? So the physio is really easy. You shouldn't miss this. Now, my question is, if it's primary, why is the gland making too much PTH? Why? Well, because it's a tumor. 80% are due to benign adenomas making too much PTH. So look for the MEN1 syndrome. It's associated with MEN1. Now, 15% are hyperplasia. Hyperplasia means all the glands are enlarging and they're working more. Now let's draw this. For adenomas, we'll see one big one doing all the work. What do the other ones look like? Tiny, tiny, tiny. Because the adenoma is making all the PTH. Makes sense. Now, if you have hyperplasia, all 4 are enlarged. Make sense? Now, here's what used to happen. The surgeon would remove this gland and send it to me. In this patient, they remove this gland and send it to me. And they say, see these big glands? Is this big gland an adenoma or hyperplasia? And what do I say? What do the other glands look like? The other ones are small? Oh, it's an adenoma. The other ones are big? It's hyperplasia. Because under the microscope, it's hard to tell hyperplasia from adenoma. There's a couple of features we can use, but it can be difficult to tell the 2 apart. So during the operation, what do the other ones look like? Here's the good news. Today, we can do intraoperative PTH measurement. We can do it intraoperatively. So question, if I remove this gland, what will happen to the PTH after 5 minutes? Because the half-life is very short. It'll go way down, right? What if I remove this gland? The PTH won't go down very much. Does that make sense? So if the PTH is still high, you got to find more glands, right? If it drops, great. You got the culprit. If it doesn't drop down significantly, then I have to find more glands. So nowadays, they just do intraoperative PTH to know did they get it all or not. Makes sense. All right, now there's another way you can get hyperparathyroid, but it's not primary. It's ectopic. Ectopic. It could be a paraneoplastic syndrome where PTH-related peptide is made by a lung cancer or a renal cell carcinoma. So that would be an ectopic. That's not primary. Primary is the glands doing it by itself. These are tumors making PTH-related peptide. Okay, now in any case, the PTH is too high. That leads to high calcium. You'll get kidney stones, and you'll see low phosphate. Now, question, if it's primary, how are you going to know? Well, routine chem panel. When you get a chem panel, you'll see the high calcium. That'll be the tip-off. You'll see that calcium. But if it gets really bad, they'll come in with symptoms. So again, most people asymptomatic, you'll pick it up with the calcium. But if you do get symptoms, you get stones, bones, and moans. Stones, bones, and psychic moans. Stones, the high calcium is going to give you kidney stones. That'll bring you in kidney stones. The calcium is being stolen from the bone. So you get osteoporosis to the extreme. What do you call it when the bones become so cystic? They call it osteitis fibrosis cystica, cystic bones. That's like osteoporosis to the max. And that's going to hurt. They're going to get bone pain and potentially fractures. And then, of course, the psychic moans is calcium is a major electrolyte for the membrane potential, right? So what's going to happen? Well, you're going to get neurologic things like depression. And what about the heart? What are you going to see in an EKG? Well, I remember like this. If you have high calcium, short QT. You see a short QT interval. Short QT. Wouldn't that be a great medical pickup line? Do you have primary hyperparathyroidism? Why? Well, I think you have it because you're a short QT. You're a short QT. If McDreamy said it, it would be different. All right, make it fun, but it will affect the brain and affect the heart. You can see shortening of the QT interval. That's cool. All right, now let's do secondary. What does secondary mean? It means the gland is not doing it on its own. It's being told to do it. Why? Because you start with low calcium. So there's some disease that gives you hypocalcemia. So secondary to that, to bring the calcium back up, the glands will kick in and make high PTH to try to bring the calcium back up. Makes sense? It's secondary to the low calcium. Now, what will happen to the phosphate? Phosphate trashing. Very good. Proximal tubule will excrete it. So the physio is not hard. If you understand the disease, you should know what's up, what's down, what's even. Great. All right, now any disease that gives you low calcium, your glands will make PTH secondarily. Makes sense. Now, what's going to cause hypocalcemia? Well, renal failure, because you're not activating vitamin D. Vitamin D deficiency. You don't get enough sunlight. You don't drink enough milk. Or how about malabsorption? It's fat soluble. So if you have celiac sprue, you can get vitamin D deficiency. Makes sense, right? All right, now I got a problem here. If it's renal failure, what will the phosphate level be because it can't trash it? Okay, if it's renal failure, you'll actually have high phosphate because it can't trash it. Makes sense? All the other ones, phosphate will be low, it'll get trashed. But if it's renal failure, it won't get trashed. Makes sense. Okay, now let's talk about the opposite. Hypoparathyroid. So again, primary, it's the gland. Let's do the primary one. It's the gland. The gland is not making PTH. So physio. If the gland doesn't make PTH, what happens to the calcium? It's going to be low. Get a low calcium. And then what happens to phosphate if it doesn't get trashed? It'll be high. So again, physio is really easy. Primary, gland's not making it. Now, John, why is the gland not making it? Your calcium's dropping. They should make it. Why aren't they making it? Well, number one, they're not there. Do you guys remember DiGeorge syndrome? They didn't form the third and fourth pharyngeal pouch. They're not there. They can't make it. Or they were accidentally removed during a thyroidectomy. You were trying to take out the thyroid gland and you accidentally took out the parathyroid glands. Now, surgeons today, they're not going to do that. We got good surgeons today. But in the past, you can accidentally remove it. And by the way, if you do accidentally remove it, you take it and put one back. You don't put it back in the neck, though. You put it usually in the forearm. So you put one back so they don't get problems with calcium. Now, another way you can destroy your glands is your immune system. If you have certain autoimmune diseases, you can destroy your gland, and that can cause primary hypoparathyroidism as well. All right, now, how does the patient going to present? Well, that low calcium is going to give you tingling and numbness in the toes and lips. This periorbital numbness and tingling is very characteristic of low calcium. Now, in addition, what would happen if I tap them here? Tap, tap, tap. You'll get Chavostics, and I blow up the blood pressure. You'll get Trousseau's
carpal spasm. So those are all signs of low calcium. Now, calcium is important for the brain and for the heart. So again, you can get depression, psychiatric problems like depression, and for the heart, well, I always remember if you have low calcium, you get a prolonged QT interval. Tell me why that's bad. Why is that dangerous? Why is prolonged QT bad? Very good. You can get torsades. Remember torsades, like a twisting of the points? Torsades. Now, why is torsades very bad? Because it's a tachycardia. VTach leads to VFib. VFib leads to the dark side. And you don't want to go to the dark side. It leads to death. So very important that we treat this. So if you get prolonged QT intervals, you're at risk for developing torsades de punt. And can you tell me, how do you treat torsades? Because I don't want to die of ventricular tachycardia. Leading to ventricular fibrillation. Magnesium sulfate. Very good. Get that mag sulfate on board to try to protect this heart. Very good. All right. Now, if you don't have thyroid glands, I'm going to have parathyroid glands. We're going to have to give you vitamin D and calcium supplements because either DeGeorge didn't form it, they were destroyed by the immune system, or they were removed by a surgeon. You're going to have to give calcium and vitamin D. Okay, we got 2 endocrine organs covered. Now we'll move to the pituitary. And this is about the tumors, but I think we need another break. Yeah, it's time for another break. Pituitary is about tumors, so again, it's a lot of pathology here. You guys doing okay with this? You're hanging in there? All right, don't worry. I'll take questions at the end. If you have questions, I'll take them at the very end. All right, let's take a break. We'll come back. We'll do pituitary and then adrenal pathology and maybe a little diabetes, and we'll be done. Okay? Why is PTH elevated and calcium decrease in end-stage renal patients? Well, without the vitamin D, what happens to calcium? Right? Kidney has to hydroxylate vitamin D to activate it. Calcium will be low. So what will the glands make? PTH. When there's low calcium, they make PTH to bring it back up. Now, the PTH will try to trash the phosphate, but the kidney's not working, you said. So phosphate will actually go up because they can't trash it. Okay, does it make sense? Very good. Very good. See, if you understand, it's like, I got it. I own it. They can't get me. All right, during the break, I'm going to send you, put the link, and I'll put them on Facebook too. Don't worry, I'll put all links on Facebook. I'll put the link for your calling so you can remember if you need motivation to remember why you do it. And I'll also put the link, if I can find it, the link for your song. The song I want you singing on the USMLA. I want you to be singing Titanium. Bulletproof. Fire away, I'm bulletproof, nothing to lose. Fire. That's the song I want you singing. Because you go in there with that confidence, that the board will have to bow before you. Right? It's all about, do you think you can do it? You can. Okay? So I'll see you guys in 10. All righty. It's our final hour together. We're going to make this count, baby. Pack in as much as we can. Then go in this exam with confidence, knowing that we've reviewed everything that's highest yield and we got this covered. So let's do more. Let's get more points. Now we're up to pituitary. This is path, the tumors. Now we divide pituitary benign adenomas into two categories based on their size. If they're bigger than a centimeter, we call them bigger, we call it macro. If they're smaller than a centimeter, we call it micro. Now, macroadenomas are big. They're likely to cause mass effects like headache and visual field problems. Remember the optic chiasm? You'll get a bitemporal hemianopsia if it's a large tumor. For small tumors, they're going to have to produce symptoms by producing some sort of chemical. Okay, so micro ones are going to be picked up because of the symptoms they get from the release of hormones, and macro ones, they can present because of visual field defects, headaches, and other mass effects. Now, what mutation is causing these tumors to grow? Do you remember the G proteins for signal transduction? Yeah, GQ, GI, and GS. This is an activating mutation in the GS gene, GNAS. This is the GS, the signaling protein. So if I mutate it so it's always on, it's going to stimulate growth. GS stimulates growth. So that's why these tumors are growing. Now, what can these tumors make? The most common is going to make prolactin. So that is really sexy, very testable. These are tumor of the lactotroph cells, which make prolactin. And the prolactin is going to cause a woman to develop a nipple discharge. Bilateral, it'll be a milky or clear discharge. Because of the prolactin, she will lactate. So she'll look down, her shirt will be wet at the nipple area, and she'll notice there's a discharge. Now, in addition, they can get amenorrhea, infertility, and osteoporosis. Tell me why. Why amenorrhea, infertility? Isn't this a problem with estrogen? Isn't that problem? Yes. What does prolactin inhibit? Prolactin inhibits GnRH. Gonadotropins don't get produced now, and there's no estrogens. That's why they get the thin bones, osteoporosis, they get infertility, they get anovulatory cycles and amenorrhea. It makes sense, right? Now, a guy. If a guy has a prolactinoma, am I going to lactate? No, we don't have enough glandular tissue. So what are we going to get? We're going to get loss of libido, we're going to get impotence, and we're going to get osteoporosis. Again, why? Because the gonadotropins, right? You're knocking out GnRH because prolactin inhibits it, therefore your gonads don't work. And that's how you'll notice it. The guy's going to be impotent. He's going to notice that pretty quickly. He's going to get osteoporosis. And it's all because of these high levels of prolactin. Now, how do you treat a prolactinoma? Well, we can try to inhibit the prolactin by giving dopamine. Dopamine agonists would be a great way to stop this tumor. Now, if it does not respond to things like dopamine, then you may need to do transsphenoidal resection of the tumor. But usually we try drugs first, and then if it fails, we'll do surgery. Now, you can also have non-functional ones. If it's not producing something, it has to create a mass effect. It'll have to get really and cause trouble that way. Now, if it makes growth hormone, that's a board favorite. If the adenoma makes growth hormone, we call it a growth hormone producing adenoma, they're going to grow. But the growth is not mediated so much from the growth hormone. It's the somatometins, the insulin-like growth factors that mediate it. So the tumor makes the growth hormone, then it acts on the liver and muscle, and they'll produce insulin-like growth factors. This is what mediates the growth. Now, if you remember, you grow slowly. So these are going to be big tumors by the time they're found because you grow over years. It takes time before you can see it growing. Now, if you get it as a child, the growth plate hasn't fused, you will become a pituitary giant. You'll literally be a giant. Now, what if you get it when you're an adult? Well, I can't become a giant because my long bones, the growth plate's fused. What bones can still grow because they don't need growth plates? The bones of the face, the skull, the bones of the hands, the bones that don't have growth plates. So acro, Acromegaly, your hands, feet, your face, these are the bones that get big. So if we look at this guy, notice how the forehead gets very square, very coarse. The nose gets thick. The bones here get thicker. Look at how square that jaw is. So you get very coarse features because these bones can still grow. So the glove don't fit, the shoes don't fit, the hat don't fit. So my mnemonic is, if the hat don't fit, think Paget and acromegaly. If the hat don't think Paget and acromegaly. Those are two diseases that give you enlargement of the bones of the skull. So if the hat don't fit, Paget, acromegaly, which one? Check the hands. If the ring don't fit, if the glove don't fit, if the shoe don't fit, that's acromegaly. Paget, you just get a big skull. Hat don't fit. That's it. They get hearing loss. That's it. All right. Now, what else do they get? Well, do you remember Andre the Giant? He had it as a kid, became a giant, and then he got acromegaly because it wasn't discovered. So he had it as a kid, as an adult, he had both gigantism and acromegaly. So tell me, what killed Andre the Giant? Well, first of all, he was a wrestler. Big people have problem with their joints. They get a lot of arthritis. So to get to sleep, he had to drink a lot of alcohol. He was an alcoholic. Now, in addition, your heart becomes huge. To all these organs, that's the big killer, heart failure. They die of heart failure. And that's what killed the giant, Andre the Giant. He was also in The Princess Bride. Do you remember he was the giant in the Princess Bride movie? Inconceivable. Yes, he died of heart failure. Now, they also tend to have diabetes. Why would these patients have diabetes? Oh, because growth hormone, the insulin-like growth factor, that's going to increase the sugar. So they often have diabetes. So they have bad joints, they have heart failure, they have diabetes. Now, as these tumors get bigger, they could get visual field defects. Do you remember the bitemporal hemianopsia? They can't see in the periphery. So in real life, do you know how it presents if they have this visual field defect? Car accidents. They crash. They can't see peripherally. They get a crash. Now, when they crash, what's the first thing the police officer asks you for? You're in a car crash. Can I see your license and registration? They took a look at the old picture of you in the license. Then they look at your current and they're like, this is not you. You're so coarse now. That's how we often pick it up, looking at old pictures. Because you grow gradually. You don't notice the changes. You don't notice it until you look at an old picture and you say, wow, it looks so different. Or like a friend from like 20 years ago comes to see you and say, whoa, you look very different than I remember. Because when you grow slowly over years. It's hard to notice it. Does that make sense? Okay, so keep that in mind. And by the way, you're young. You don't understand this. The worst day of your life is the day you have to go to the DMV and get a new picture for your license. No, I want to keep, when I was 18, I want that picture. I was young. The new Barone is as good as the old one. Can I keep this picture forever? You got to change your picture every 10 years. No. I know. That's why I think in Arizona, it's every 50 years you have to get a new picture. I think I'm going to move there just so I can keep the same picture, the young picture. Yeah. I think it's one of those states nearby. It's like they don't take their picture every 5 years or 10 years. All right, I'm making a joke here, but this is very, very important. You pick it up by looking at the old pictures and you see how much they've changed. Now, does anybody remember the story from the Bible? It's also in the Quran as well. Do you remember the story of David and Goliath? Goliath had a pituitary tumor making growth hormone. That's why he was a giant. That's why he looked so coarse, his facial features. And he put him in the front of the army. Because when he came, you're like, oh my God, they have giants. Unless we have Jon Snow, I'm out of here. I mean, he must have been an imposing figure, right? Giant with acromegaly. How did David beat him? With the sling. The sling. It's coming from the side. He never saw it coming. It hit his head. This tumor ruptured and bled. That's called apoplexy. Apoplexy is when it bleeds into itself. The pressure goes up. By the time you hit the ground, you're herniated, you're dead. One blow killed the giant. It could have happened. Are you not entertained? Explanations of the Bible? It could have happened. It's in the Quran. It could have happened. Wow. Mind blown. Cool. All right. So very testable, this growth hormone producing one. They like it. All right. Now, what about Sheehan's? Well, if you're going to be an OBGYN, that's when you're going to see this. This is ischemic necrosis of the anterior pituitary because of severe hypotension after the delivery. Remember, every delivery, there's bleeding. If there's severe bleeding, like an abruption, and you get hypotensive, that's when you infarct it. Because here's the pituitary. We got the anterior pituitary and the posterior pituitary. Now remember, how do I know this is posterior? Because it's attached to the stalk, right? ADH comes down and goes into the posterior. This is the anterior. It doesn't have to be next to the stalk. Now, they have different blood supplies. Anterior gets a blood supply. Posterior gets a blood supply. They have different blood supplies. Now, when you get pregnant, the anterior pituitary has to do double the work. So it will literally double in size. The posterior is the same. The intermediate is the same. The anterior is huge. But the problem is it doubles in size, but the blood vessel doesn't change. It doesn't change. So all women, when you are pregnant, your pituitary anterior part gets really big and it's borderline ischemic. It's okay. It's borderline ischemic, but it's okay. But what happens if you get severe hypertension during the delivery? Then the anterior will infarct, not the posterior, anterior. That is called Sheehan syndrome. It's postpartum hemorrhagic necrosis of the anterior pituitary because it doesn't get enough blood flow. Now, all the anterior hormones are missing. So what's going to happen now? She won't be able to breastfeed. Prolactin is missing. ACTH, the adrenals are going to fail. TSH, the thyroid. So ACTH, TSH, LH, FSH. The ovaries aren't going to work. Growth hormone. She won't grow anymore. So all these hormones are going to have to be replaced. The first one you're going to notice, though, since you just delivered, is they won't be able to lactate. They're going to tell the vignette, the baby is latching beautifully. The baby is sucking beautifully. But the baby starts crying because there's no letdown of milk, because there's no prolactin. Make sense? All right, so that's the earliest clue that something's wrong with the anterior pituitary. All right, now what about posterior pituitary? Well, in the posterior, there's only two things. You got oxytocin. There's no disease of oxytocin. And there's ADH. ADH, they're opposite diseases. We have diabetes insipidus and the syndrome appropriate ADH secretion. Here, ADH is low. Here, ADH is inappropriately high. They're like opposites. Now, for diabetes insipidus, we have two types. We've got the central one, which is the most tested, and there's the nephrogenic one they'll ask about for pharmacology. Now, for the central one, this is a deficiency of ADH because of some sort of head trauma. When you have head trauma, you can rupture the stalk. Do you remember ADH comes down the stalk? Goes down the stalk, gets released in the posterior. Well, if you rupture the stalk, ADH can't get down there. So head trauma where you damage the stalk, or maybe a tumor damaging the stalk. Something damaged the stalk, that's why you get ADH deficiency. Now think about this. If you're missing antidiuretic hormone, what are you now going to do? You're going to diurese. You're going to produce a tremendous amount of dilute urine. You're losing water. You're losing free water. You're peeing it all out. So you're going to get thirsty. So what are you going to do? You're going to drink it back in. So here's the good news. As long as I can drink, there'll be no problem. I'll pee out a whole bunch. I'll drink it back in. As long as I can drink, you'll be okay. But what if I'm passed out? What if I'm in a prison? I can't get access to water. What if I'm on a desert island? That's when you're going to have trouble. Because if you can't drink, you'll now get dehydrated in your body. In fact, what will the sodium level appear to be because all the water is gone? It'll appear to be high because it's nothing to dilute it. It'll be really high. Now, you're now going to have electrolyte imbalance of the nerves. So now your heart's not going to work, your brain's not going to work, and this will kill you. when you get electrolyte imbalances like this. This will literally kill you. Make sense? So, makes sense. You got to know this one. Now, how are you going to treat it? How are you going to treat an ADH deficiency? You'll never guess. Number one, have them drink. But what if they can't drink? They're unconscious. Give them ADH. Give them desmopressin. Make sense? So have them drink. If they can't drink, give them desmopressin. And then hope that the stock repairs itself. Makes sense, right? All right. Now, what about nephrogenic? Well, nephrogenic is not a deficiency. You actually have it, but it doesn't work because you're taking a drug like lithium or demeclocycline. So lithium, demeclocycline, those drugs are going to inhibit the ability of the receptors to recognize it. So the kidney's not going to respond to it. You have the ADH, it doesn't work. That is the nephrogenic form. So question, if I gave them ADH, is that going to help them? No, it's not going to help them. We need to stop the drug. So stop the lithium, stop the demeclocycline, stop the drug, and then open the aquapores, right? Okay. All right. Now let's do the opposite. Opposite of this is having too much ADH, like the syndrome of inappropriate ADH secretion. So for ADH secretion, who's going to be secreting it? It's usually going to be a tumor. So we got to think about lung cancer. Do you remember small cell of the lung? Small cell lung cancer? Yeah, small cell lung cancer is going to cause this. Now, another thing you can do is head trauma. If I hit you in the head, you can release, because of the trauma, you can release out ADH inappropriately. But on the exam, it's usually going to be paraneoplastic of small cell lung cancer. Now, if the tumor is making too much antidiuretic hormone, what's going to happen? Well, now you're not going to diurese. You're going to hold on to that free water. You're going to swell up. You're going to produce very little concentrated urine. You're holding on to the water. Okay. Antidiuretic. You're not going to diurese. So what's going to happen here? You're holding on to it. You make very little urine. You're retaining the water. So what's the sodium level going to look like? It's going to look low because it's diluted. It's diluted out. You're swelling. Now, the problem is your brain. If your brain swells, you can die. This can kill you. So this is potentially very dangerous. So how are we going to treat this one? Well, number one, don't let them drink. Fluid restriction. If they drink, they'll hold on to it. Number two, do you remember the Vaptam drugs? We're going to use the Vaptam drugs, those aquifer, those, what are they, water pores, to try to get those things to open so you can get the water out. Okay, makes sense? So use the Vaptam drugs here. And then if it's like a tumor that you can't cure, it's going to be forever. Well, we can reverse it. We can reverse it by doing this. Give you a drug to cause nephrogenic diabetes insipidus on purpose. If I cause now it won't respond to the ADH. That's great. You're reversing the disease. So what drug can I give you? If it's going to be a tumor that I can't cure, you're going to have to live with this. Well, I can give you lithium, but lithium will mess up your brain. So we're going to use demeclocycline. Demeclocycline. It's an antibiotic, demeclocycline, that we can use for chronic cases that we're not going to be able to cure. Okay? All right. Got it? Good. All right, good stuff. I'm glad you guys got it. I know whenever you integrate with pharm, students can have trouble, but you guys nailed it. You're all over it. Okay, now the last of the endocrine organs is the adrenal gland. We have two parts. We have the cortex, which makes your GFR, glomerulosa, fasciculata, reticularis, right? Glomerulosa, your aldosterone, fascicularis, your sugar, your glucocorticoids, and reticularis, your sex hormones. The deeper you go, the sweeter it gets. And then we have the medulla, which makes epinephrine and norepinephrine, so you can get tumors like pheochromocytomas. So that's what we got to cover. Now let's start with the cortex first. Let's talk about hyperfunction. So something like making too much glucocorticoids would be Cushing's. If you make too much mineralocorticoids, that'll be primary hyperaldosteronemia, like Conn syndrome. And if you make too much sex hormones, that's called the, genitals, the adrenal genital syndrome. You're going to get virilized from the sex hormones. So again, too much sugar, fasciculatus, that's
Cushing's, too much mineralocorticoids, that's the primary aldosteronism, and then you get the genital adrenal syndromes with the reticularis. All right, now Cushing's is going to be producing too much glucocorticoids, so you're going to get the classic features, right? You're going to get the hypertension, the weight gain in the truncal area, the buffalo hump, the moon facies, the purple stria, the hair growth, the mental disturbances, and the osteoporosis. By the way, it's the only obese patient with osteoporosis. Obese patients don't get osteoporosis. They got aromatase. They got estrogen. So obese patients have high estrogen. They don't get bone osteoporosis, except for Cushing's. It's the one time you'll see an obese patient with a bone loss because the glucocorticoids. All right, now I got a question for you. How do I know that glucocorticoids are high? How do I diagnose Cushing's? I got the symptoms, but how am I going to diagnose it with certainty? Okay, well, there's 3 ways to know. There's 3 ways to know that the cortisol's high. Number 1, you can measure it in the urine, a 24-hour urinary cortisol. Right, you got to collect it because the cortisol fluctuates throughout the day. So a 24-hour urinary cortisol, if it's high, great. All right, a second way to do it, to diagnose that there's high cortisol, is measure it once, late night, like midnight. A late night cortisol, because late at night, what should cortisol be? Should be the lowest. Should be the lowest late at night. So at midnight, measure cortisol. If it's low, that's a pretty good diagnostic test, a late night cortisol. And then finally, we can also do the dexamethasone suppression test, an overnight dexamethasone suppression test that can do it, the diagnosis as well. So let's repeat. How do I know you got Cushing's? You're going to see all the classic symptoms, but you can't just guess, you have to prove it. So I need to find high cortisol. You can do it with a 24-hour urinary cortisol. You can do it with a late night cortisol measurement, or you can do it with an overnight dexamethasone. That's how you prove the patient is Cushing's. Now, etiology is the next step. The most common cause is iatrogenic. Doctors give prednisone all day long, and we know you get Cushingoid from it. This is not a diagnostic dilemma. We know we're giving it, okay? So the diagnostic difficulty are these 3. It could be a pituitary tumor of the pituitary gland, could be adrenal tumor, benign, and it could be an ectopic production by a paraneoplastic syndrome of lung cancer or renal cell. So that's our job. We have to distinguish these 3 etiologies. Cushing's disease, Cushing was a neurosurgeon. So Cushing's disease, give it a different name, it's usually syndrome, but you call it disease when it's a pituitary adenoma, because he was a neurosurgeon, Dr. Cushing. It could be ACTH from ectopic tumors, and then it could be Cushing syndrome because of an adrenal tumor. So that's your 2 steps. First step, prove it's Cushing's with the 3 tests. Do one of those. Then you prove the etiology by doing 2 more tests. You need 2 more tests to tell etiology. Okay, so once I know cortisol's high, you got Cushing's, now I need to see which it is. So if it's a pituitary tumor, the pituitary adenoma is making high levels of ACTH. So that's what we're going to measure. We'll measure ACTH. Now, if it's high, there's a problem. It could also be high by tumors of the lung or kidney. They could be making ectopic levels of it. So ACTH will be a first test. That'll definitely tell these 2 guys from this guy has it low. Okay, so definitely distinguish it from the adrenal cause. But it won't tell a pituitary tumor versus an ectopic production. Now, what is the ACTH going to do for both of them? It will stimulate the adrenal gland. So what are we going to see? We're going to see bilateral enlarged adrenal glands, and that's why the cortisol is being produced in high levels. Make sense? Makes sense. Same thing over here. ACTH is going to stimulate the adrenals. They're both going to be enlarged, and that's why there's high levels of cortisol. Makes sense. So how are we going to tell these 2 apart? They both have ACTH.
you're going to do the dexamethasone high dose suppression test. You can do low dose as well, but it doesn't suppress anything at low dose. Only the high dose will work. Now, here's the rule. It never works except for the pituitary. The only time dexamethasone ever suppresses is if you use high dose and it is in a pituitary tumor. Because think about that. Lung cancer. Does lung cancer care about dexamethasone? Lung cancer is going to say, you're going to try to suppress me? I'm lung cancer. I'm not going to listen to you. Right? It's not going to affect it. Low dose, high dose, nothing is going to suppress it. Make sense? It's a lung cancer. It just keeps spreading, killing you. Makes sense. All right. Now, is an adrenal tumor going to respond? No, adrenal responds to ACTH. Dexamethasone, cortisol, that's not going to affect it. So it won't suppress with adrenal. The only thing that's supposed to respond negative feedback to things like cortisol and dexamethasone is the pituitary. That's the only one who's supposed to respond, right? Now, it's a tumor, so it doesn't respond to low dose, but it will respond to high dose. So if the dexamethasone high dose suppression test ever suppresses, you know now it's a pituitary tumor. So now we'll get a CT or MRI of the Sellica turcica to find the tumor. So here's a good rule. In endocrine, never radiology first. Never. If you do scanning of the adrenal gland, pituitary gland, you're going to find nodules. And you won't know are they important or not. So never image endocrine organs first. Always biochemical first. Once I see, okay, ACTH is high, and then it doesn't suppress with the, or it does suppress with the high dose, it does suppress, then we do imaging, and we'll see if there's nodules in the pituitary. Make sense? Don't image it first, because if you see a nodule, you won't know if it's important or not. You'll find nodules all the time in endocrine organs. So make sure you find biochemical evidence first, then do imaging. Now, vice versa. If the ACTH is high and it doesn't suppress, now we need to do imaging of your lung and kidney. Bronchogenic lung cancer and renal cancer needs to be looked for. Make sense? Okay? All right, now let's change it. Let's change it. If it's an adrenal tumor of the cortex making cortisol, what will the adrenals look like? Well, I'll have a tumor in the cortex, but the rest of the gland will be small. What about the other gland? It will be small because this tumor is making all the cortisol. So the remainder of the gland is tiny and the other gland is tiny because the tumor's making all the steroids. Make sense? Now, all this cortisol is going to give negative feedback on the pituitary. So what's the ACTH level going to be? It's going to be really low because all the cortisol giving it negative feedback. Okay? So really it's a 1 second diagnosis. If you have Cushing's and ACTH is low, it's the adrenal. It's the adrenal. So immediately we'll now image the adrenal gland and look for a tumor of the cortex, and then we'll try to remove it. Okay, so we'll do an MRI of the adrenal, and we'll look for the tumor. Again, never radiology first, always biochemistry first. Okay, got it? The first time you understood it? Wonderful. So how many tests do I need to know for Cushing's? There's actually 3. Number 1, I have to diagnose Cushing's by using one of these. So first test is to diagnose Cushing's. 24-hour urine, late night cortisol, or low dose overnight dexamethasone test. That's how you prove that it is Cushing's. Then you have to do etiology. 2 tests. Start with the ACTH because pituitary tumors are the most common. So start with ACTH first. If ACTH is high, you're thinking it's pituitary, but it could be ectopic. So let's do the high-dose dexamethasone test. If it suppresses, now we image the pituitary. If it doesn't suppress, we image the lung and the kidney. Makes sense? Now, on the other hand, if the ACTH was low, then we know right away it's going to be adrenal. So you can image the adrenal and you will see the tumor. And then you could try to resect it, right? Okay. Cortisol gives negative feedback on the pituitary. Correct. It does. But question, will it give negative feedback on an adenoma? No, not unless it's high dose. So physiologically, it won't give negative feedback. So ACTH will be high from the tumor. It'll be high because the tumor is going to make it. It'll only stop making it if you give high dose analogs like dexamethasone. Okay, got it? This is good. I like understanding. When the light bulb comes on, you're like, oh yeah, prove it's Cushing's, and then determine what's the cause, and you're ready to rock. Now, what if I have a tumor of the cortex of the adrenal gland, but it's not making cortisol? It's making aldosterone. Well, that's called hyperaldosteronism. Your adrenal gland is making too much aldosterone, so aldosterone will be elevated. Now, it could be primary or it could be secondary. Secondary to what? Well, question, if you have hypotension, so you have renal artery stenosis, blood is not getting to the adrenal gland, what will they make? Well, the kidney's not getting blood flow. What does the kidney make? Well, it's going to make renin, right? Doesn't feel it. Going to renin. Renin, angiotensin, then aldosterone will go up secondarily. Does that make sense? It'll go up secondarily. So, if you want to know if it's secondary, check the renin level. If the renin level's increased, it's secondary. The aldosterone is elevated because the renin, angiotensin, aldosterone system. Does that make sense? You started with low perfusion of your kidney, low blood pressure or renal artery stenosis. The kidney made renin. That's why the adrenals made it's secondary. That's normal. Now, primary means the adrenals making it on its own, usually because it's a tumor. It's a tumor. So you have an adrenocortical tumor, like an adenoma. We call this Conn syndrome. Now, does it have to be a tumor? No, it can also be hyperplasia. Hyperplasia can make too much as well. It's just proliferating. So usually it's going to be a tumor on exam, but hyperplasia is actually more common in real life. Now, why are tumors going to be yellow? Because cholesterol. So cortical tumors are going to be bright yellow. Any cortical adrenal tumor is going to be yellow because cholesterol is the precursor for hormone and steroid synthesis. Now, I have a question for you. If it's a tumor, the tumor is making the aldosterone, what will now happen? Well, you're now going to hold on to salt and water, sodium and water. You'll hold on to it. So what will happen to your blood pressure? You'll now get hypertension. Okay, makes sense. Aldosterone increases blood pressure, right? By the way, what does it do to potassium? It wastes it. You'll see hypokalemia. That's a very important clue. In the United States, lots of people have hypertension. But if I ever say hypertension with hypokalemia, that's when you start looking for primary hyperaldosteronism. Okay, start to get about hyperaldosteronism. You have hypertension with low potassium. Hypokalemia. All right, I got a question for you. What does that cause? Weakness. They're really weak. Their muscles. Weakness. So they get this hypertension with really weak muscles. Check the potassium. Oh, okay. All right, now question. What's the renin level going to be? If you already have hypertension because of the aldosterone being produced by a tumor, it's going to be low. So how do I tell a primary process versus secondary to hypotension? Check the renin. If the renin is low, it's the adrenal gland making aldosterone on its own. If the renin is high, the adrenal gland is making aldosterone because it's being told to by the renin, angiotensin, aldosterone system. Make sense? See, it's all physio. If you know your physio, you can't miss it. All right, now what about the tumor of the cortex that makes 17 ketosteroids, the tumor of the reticularis of the cortex? That is going to cause sex hormones and your genitals will become virilized. So this is any adrenal disorder where you make too much sex hormones and you get virilized. That's the adrenal genital syndrome. So excessive production of androgens and virilization of the patient. Now this could be due to a tumor of the cortex. So it'll be a bright yellow tumor. It could be an adenoma or a carcinoma. Either one likes to make androgens. Now, it could also be due to the biochemistry disorder, where the adrenal can't make it because of the enzyme deficiencies. Do you remember congenital adrenal hyperplasias? There were 3 major ones. Do you remember you have 21 hydroxylase deficiency? You have 17, and you have 11. So there were 3 different syndromes, but only 2 of them virilize you. Which ones virilize you? Well, first number tells you the blood pressure. Second number tells you what happens to the genitals. So what is this? What is this? Those are not lollipops I'm drawing. That is clitoromegaly. That's virilization. Now, the first number is the blood pressure. So this is going to have hypertension. Hypertension. Now, a 2 goes like this. A 2 goes like whee down. So I never miss it. 21 has low blood pressure, and if they're a girl, they get virilized. 17 has high blood pressure, but no virilization. And then 11 has high blood pressure, and if they're a girl, they're virilized. Now, if they're a boy, you can't get virilized if you're a boy, right? You're already virilized. But if they're a girl, they'll get virilized. Makes sense. Okay, so any adrenal disorder where you make too much sex hormones, you get virilized, clitoromegaly. All right, now let's talk about not enough cortical function. You can destroy the cortex rapidly. That's called Waterhouse-Friderickson's, or acute cortical insufficiency. Or you can destroy it slowly. That's called Addison's, or chronic adrenal cortical insufficiency. Now for acute, this one's really bad. This is usually a kid who gets meningitis. So do you remember meningitis with Neisseria? You get a petechial rash. Petechial rash because it releases tissue factors. It triggers clotting. Well, guess what? If I don't treat it, number 1, you'll get septic, so your blood pressure will drop. And number 2, you'll trigger lots of clotting, and DIC will occur. When you get DIC, all those clots of the adrenal, now the adrenal will get bilateral hemorrhagic infarct. John, why is it hemorrhagic? Here's why. 1 artery comes in, 3 veins come out. 3 arteries come in, 1 vein comes out. Got it? So there's 3 adrenal arteries, there's 1 vein. Great. So if I clot this artery, what happens? Nothing. Got 2 other arteries. If I clot this vein, what happens? It infarcts. And it's hemorrhagic because your blood can't get out. Does that make sense? So normally there's 3 arteries going to the adrenal, only 1 vein coming out. So if you start clotting and have low pressure, if you clot one of the arteries, no big deal. You got 2 arteries, they're open. If you clot the vein, there's only 1 vein. You're going to get hemorrhagic infarction because blood can't get out. Make sense? Make sense? All right. So this is a very bad thing because you can die from the sepsis, you can die from the DIC, and you can die from the acute adrenal cortical insufficiency. So this is a very bad thing. To treat this, you're going to have to treat the infection, give pressors, get that blood pressure up, and you're going to have to replace the mineralocorticoids and the glucocorticoids. It's the only way you're going to survive. So this has a high mortality. Now, if you destroy it slowly, you can survive. There's plenty of time to adjust and give you a replacement. So if you get chronic destruction, that's called Addison's disease. This is where you destroy the cortex, so we lose our sugar, our salt, and our sex hormones. Now, what's the most common cause of this today? It's autoimmune. Autoimmune adrenalitis, that's the number 1 cause of Addison's, but back in the 1800s, it used to be TB. So TB can still do it. It's just not common to see TB in the US anymore. It's kind of been wiped out. So TB can do it as well. Now, metastatic cancer, if it goes to both adrenals, it can cause it. Do you remember lung cancer? Lung cancer has tropism for adrenals. So if it's metastatic cancer, it's usually going to be lung cancer that can cause this. Kind of rare, but it can occur. Now, presentation, sugar, sex, and salt, they're all going to be missing. So you're going to get very, very weak because of glucocorticoid deficiency. You're going to get hyperpigmentation because if you don't have cortisol, ACTH will be sky high. If you remember, the first part of ACTH is melanocyte stimulating hormone. It's part of this ACTH molecule. So that's why they get the bronzing, especially in the crease areas. Classic. Hypotension is because of the mineralocorticoid deficiency. Hypoglycemia is the glucocorticols, and also the stress. Poor response to stress is all about glucocorticoids. And loss of libido, that's going to be your sex hormones. Now, can anybody tell me What president was really dark? He looked like a movie star. Really dark? All right, well, we had Obama. He looked like a movie star, that's true. But I was trying to talk about John F. Kennedy. Do you remember John F. Kennedy? He looked like a movie star, looked so tan, right? He had Addison's disease. He had Addison's. And did he make some bad decisions during his presidency? Do you remember the Bay of Pigs? We almost had World War III. Yeah, he's fighting the Russians on Cuba. We almost had World War III. So he made some bad decisions. That makes sense. Now, clearly, he was getting great hormone replacement. Why? No loss of libido. Happy birthday, Mr. President. Right? Kind of had an affair there. Maybe not. That's controversial. But I think his libido was okay. So he was getting pretty good replacement. Luckily. All right, now what about tumors of the adrenal medulla? Do you remember the pheochromocytoma, a dark, dusty tumor? Now, in real life, this is kind of rare. You don't see this very frequently, but you will on exams. They love these tumors on the exams. So it's a dark, dusky, ugly pheochromocytoma. Now, it's a benign tumor in most cases, which is good. Okay, usually benign. It's in the adrenal medulla in most cases. Now, since it makes catecholamines, norepinephrine, and epinephrine, we would expect to get episodes of hypertension, tachycardia, palpitations, sweating, anxiety. And what will we look for in the urine? The breakdown metabolites. What's the breakdown of catecholamines? Well, one of them is VMA, vanilmandelic acid. Another one is homovanillic acid. But what's the best test? VMA is good. HVA is good. Homovanillic is pretty good. But what's the best one? Metanephrines. Look for free metanephrines. And you could find them not just in the urine, but in the plasma too. Okay, these two are in the urine. This is in the plasma. Free metanephrines. How do you spell metanephrine? P-H-R-I-N. Metanephrines. This is your gold standard. So you can look for them all. In real life, we'll order all of them. We'll order VMA, HVA, and metanephrines. But if I can only pick one, metanephrines is our gold standard for diagnosing pheos and also for diagnosing, remember babies, they get an adrenal tumor called neuroblastoma? Neuroblastoma, it's like a pheo, but it's malignant. It's in a baby's adrenal medulla. You also use it for diagnosing them as well. Okay, so metanephrines is our best test to look for in the plasma or the urine, either one. All right, now for the microscope, there's a cool pattern here. These tumor cells make nests. They look like balls. So the growth pattern is called a Zellballen. It's like a gangster tumor. You see me rolling. I'm balling, baby. I'm balling. Zellballen pattern. So gangster. Now, how do you treat these tumors? You need to resect them, laparoscopically resect them, but I can't resect you with hypertension. So first, we have to control the blood pressure. Then we'll do a laparoscopic resection. So a famous question for pharma is, what drug do we classically use first to try to control the blood pressure? Yeah, we're going to use alpha, non-specific alpha blockers first, like phenoxybenzamine. Do you see pheo in the name? Do you see pheo in the name? It's got pheo in the name. Pheo is in there. So we use the non-selective alpha blockers first. Why not beta blockers first? Why don't you do beta blockers first? Because you'll get unopposed alpha and you'll actually get paradoxical hypertension. So we always do alpha blockers first. If they're not sufficient, add beta blockers to it. But start with the alpha drugs first. Makes sense. Okay, phentolamine can also be used usually during the surgery. We use it during the surgery. So phenoxybenzamine before surgery, phentolamine during the surgery. Very good. Okay, now, do you remember the rule of tens? There's a rule of tens here. What does that mean? Well, 10% are in kids. That means 90% are in adults. They're in adults. 10% are bilateral. That means 90% are unilateral. Most cases are just one adrenal. 10% are malignant. That means 90% are benign. They should have done a 90% rule. That would have been better. What else? 10%, no, I got to change this. 25% run in families. So that's important. 1/4 have familial. So you better check for other tumors, particularly MEN syndrome 2A and 2E has the medullary thyroid, and that will kill them. Medullary thyroid kills you. Pheos are not going to usually kill you because they're benign. Medullary thyroid cancers kill. So here's the rule. If I ever see a pheo, I'm going to look for germline RET mutations. If you have a germline RET mutation, not just in the tumor has a RET mutation for sure. If your germline has it, you have MEN syndrome, I will now do a prophylactic thyroidectomy to prevent medullary cancers. If you don't do that, that's a lawsuit. You left the thyroid there, and then they get medullary and die? That's on you. So anytime you see a pheo, we have to see 75% of the time, it's sporadic, bad luck. But 25% of the time, it's a germline mutation. So it's a familial case. If you see a germline mutation in their cells, you need to remove their thyroid gland to prevent medullary carcinoma thyroid. Very good. All right, last rule. 10% are outside the adrenal, which means they're mostly in the adrenal. Question, what's the name you use when they're out of the adrenal in the sympathetic ganglia? They call it a paraganglioma. Paraganglioma. That's just another name for a pheo when it occurs outside the adrenal gland. And I always get these emails. Barone, it was a pheo. It was a pheo VMA. It was a pheo VMA hypertension. It was a pheo. I was like, so why are you emailing me? Because it wasn't there. I was like, are you sure? Was paraganglioma there? He goes, yeah. That's a pheo. That's what you call it when it's outside of the adrenal gland. He's like, oh, man. I know. They like to do that. When there's more than one name, they like to do that. All right. Now, we didn't do much music today because we were trying to get through material. So here's some music for you. You can watch it during the break. Nice music, a little pheochromocytoma. It's my Spanglish version, a little Spanish and English. Okay, now let's finish this chapter with two things. We got diabetes and we also have MEN syndrome. Now, question, men, are they dominant or recessive? All right, we're having some controversy here. Let's rephrase. Men, do they think they're dominant or recessive? Okay, they think they're dominant. Who wears the pants is controversial, but they think they are. So these tumors think they're dominant. So this is going to run in families. You're going to give it to half your kids. They think they're dominant. Now, this is a syndrome where you're going to get neoplasia of your endocrine organs. So hyperplasia and tumors of your endocrine organs, and they're going to occur at a relatively young age because it's a germline mutation. Now, there's three types. Now, for MEN1, also known as Werner syndrome. John, it's Werner, close enough. So I remember MEN1 is called Werner's, close enough. Now this is called the 4 Ps. The 4 Ps. You're going to see benign adenomas in your pituitary gland. That's your first P, pituitary. So start up here, pituitary. You'll see prolactinomas, growth hormone producing tumors, ACTH producing tumors. You're going to see those pituitary tumors. Number 2, next to the thyroid is the parathyroid gland. That's going to make high levels of PTH. So you're going to get high calcium. You're at risk for kidney stones. All right, number 3, you're going to have adenomas of your pancreas. So 3 adenomas: pituitary adenomas, parathyroid adenomas, and pancreatic adenomas. Now, pancreatic adenomas, they can make insulinoma, or they can make gastrin. Do you remember gastrinomas? Gastrinomas can cause Zollinger-Ellison syndrome, where you get peptic ulcers in the stomach, the duodenum, and the jejunum. There's your 4th P. So I call it the 4 Ps. First 3 Ps are endocrine adenomas of the pituitary, parathyroid, and pancreas. And if they got a pancreatic gastrinoma, a G-cell tumor, they'll get the 4th P, which is peptic ulcers all over the place. All right, now what's the gene that's you're born with a hidden? MEN1. How convenient. The MEN1 syndrome has MEN1 gene mutations? Probably not going to ask that.
What protein does it make? It makes a protein called menin. Men1, little Roman numeral 1. Men1, menin. Too easy. Now, much more likely is MEN2 because they thought it was one syndrome and they realized it was slightly different. So they divided to 2A and 2B. 2A and 2B. John, this isn't simple. No, it's simple. It's not simple. It's sipples. It's very complex. 2A? This isn't simple. It's sipples. Now, they're going to have two tumors in common. They both are at risk from medullary carcinoma thyroid, which is a malignant tumor, makes calcitonin. All right, they're also at risk for benign tumors called PHEOs with the epinephrine, norepinephrine production. So those are the two tumors they have in common. So how do I tell them apart? Well, you got to add something. They got to add something to make it unique. What can they add to 2A? Parathyroid things. Parathyroid hyperplasia, parathyroid adenoma. In other words, you're going to have high PTH and high calcium. So if I say you have a PHEO and a thyroid cancer and you have high calcium, that's going to be 2A. Now for 2B, what we'll add differently is we'll add benign neural tumors, usually in the skin or the GI system. So neuromas, neurofibromas, ganglioneuromas. Okay, so give me these benign neural tumors with the PHEO and medullary, then I'll say 2B. Or give me Marfanoid features. Marfanoid, not Marfan syndrome, the Marfanoid features. Marfanoid features. So the long, the tall height, long extremities, a spider-like arachnodactyly. Give me those Marfanoid features, and then I'll pick it. Question, what president was really, really tall? Long extremities, big hat. What president do we think had Marfanoid features? Abraham Lincoln. Abraham Lincoln. We think, he didn't have Marfan's, we think he had Marfanoid features of MEN2B. We think he was meant to be the president. Really, they think he had MEN2B. If he didn't get assassinated in that theater, he might have lived long enough to get a PHEO or medullary carcinoma. But he was assassinated. They really think he had MEN2B. That's why he was so tall and thin and lanky. Marfanoid features. Isn't that cool? See what you learn in my class? Go to the History Channel. He was meant to be the president because I think he had MEN2B. So tall. Imagine a guy that tall. You're gonna be like, yes, sir. Yes, sir. You should be the president. You're so tall. You're meant to be the president. People will listen to you. Yeah, and Hollywood says he was a vampire slayer too. I don't know if that's based on fact though. I don't know if that's based on fact. All right, now we're out of time, but is it okay if I just do a little more? Let me do a little more. Let me go a little overtime. Now my TAs, my content TVs, if you need to leave, go ahead because they don't pay them. They don't pay them if we go over. So I'll stick around for you because I don't care. I care about you. But they can go, okay? So if you ask questions, you have to type in the chat because they won't be here. Okay? I'm going to stick around a little bit longer because I just want to finish this part. Okay, now for diabetes, there's not much I can teach you, right? You know diabetes, type 1, type 2. Now, for diabetes, we know it's a chronic systemic disease where either insulin is deficient or you have peripheral resistance of your tissues to it, so it doesn't work so good. Now, in either case, you're going to have high sugar. Why is high sugar bad? Well, for two reasons. It's sticky. Pour some sugar on me. It's sticky. It's going to stick to your proteins and cause non-enzymatic glycation. It's going to cause a thick base of membrane, damage your membrane. It's going to damage your proteins. Now, what else does it do? It attracts water. So if you get high sugar inside a cell, you're going to get osmotic damage. What's it called when your lens swells and you can't see? We call that a cataract. Osmotic damage of the lens. The Schwann cells swell up. You get peripheral neuropathies when you lose myelin because they get all swollen. So let's repeat. What's the bad thing about having high sugar? If I keep sugar normal, you'll have no pathology. If your sugar's high, you're going to damage your proteins non-enzymatically, and you're going to swell your cells. You get cataracts and loss of myelination because Schwann cells get injured. Makes sense, right? All right, now let's talk about diagnosis. My grandma has diabetes. How do you diagnose it? Well, there's several ways. Number one, you could do a fasting glucose twice.
on 2 separate occasions. If it's over 126 when you're fasting, that's diabetes. Now, pregnant women, do you make pregnant women fast? They will kill you. No, you do the opposite. You say, here, drink this really sugary liquid. We're going to challenge you with sugar, see if you can pack it away. And they're going to hate that too, because it's really sweet. They don't like it, but it's better than saying fast. They rip your head off. Pregnant women can eat whatever pregnant women want. And gentlemen, get out of bed and go get them the pickles. And it's the least you can do. They're doing all the work, right? All right, so that's called a glucose tolerance test. If they can't get rid of the sugar, that's a positive glucose tolerance test. We often do that with pregnancy. Now, another way you can diagnose it is the hemoglobin A1C level, right? So elevated hemoglobin A1C. And then a fourth way is a random glucose. If you ever do a random glucose, non-fasting, just walk up to you, do a glucose, and it's over 200, a random glucose over 200, that's diabetes as well. So again, we have a lot of ways of diagnosing. Now, why is this the one they like to test? Because not only does it diagnose diabetes, but this is how we follow you to see if you're cheating. See, my grandma, she cheats. She's got diabetes, but she has ice cream all the time. And I'm like, Grandma, you can't have ice cream. You have diabetes. She goes, no. I just stopped the week before I see my doctor. I just stopped the week before. He doesn't know. Grandma, he knows you're cheating, because that's what they do, right? They know they're going to see you next week, so they take their meds, they exercise, they eat right. Then they come in and say, Doc, look, this whole week my finger stick glucose was perfect. Great, this week you're in control. Let's see, you've been cheating over the last several months. Because blood lasts for 120 days. This blood has seen the sugar level over the last few months. So she thinks she's getting away with it. He knows she's uncontrolled because he gets the hemoglobin sky high. Makes sense? And she thinks she gets away with it. And it's so funny because every time her sugar's high, she makes them print it out. She makes them print it out because then she can go to the boardwalk and show all the guys, look, I'm sweet. I have proof. I'm sweet. You should hang out with me. That's why my grandma is 99. She has a reason to live. She's got a boyfriend on the boardwalk. She's got a boyfriend over in the Camana. She's got a boyfriend. She's got 8 boyfriends. Right? Have a reason to live, and you live. And I love her. She's got this T-shirt. It's a woman's skeleton. It's a woman's got a woman flowery hat, got the purse. It's a woman's skeleton, and it says, waiting for the perfect man. That's why she's a skeleton. I'll be honest, there are no perfect men. We're all broken. Ladies, sue Disney. Sue them. Sue them. It's false advertising. All men are broken. So find the least broken guy you can stand and grab him. And vice versa, gentlemen, they're not perfect either. There's no perfect women. That was airbrushing. There's no perfect women, right? But there could be a woman who's perfect for you. If she's broken in the ways that you can stand, that's why it's so good. If you were perfect, she wouldn't want you. If she was perfect, she wouldn't want. Perfect people don't want each other. They're perfect. So we're broken in compatible ways. So you find somebody who makes you better. That's what you're looking for, right? Yeah. Not somebody who makes you whole. No, you're whole by yourself. Somebody who makes you better, right? If you say somebody has to complete me, that means you're not complete. No, you are complete. You're perfect the way you are, but you want to be more, right? All right, sorry. Now, 2 types of diabetes, we know these. These are straightforward. Type 1 is going to be 10% of cases. It presents young. Most cases are going to onset in the childhood or adolescent years, usually less than 20. Now, what if I say a 60-year-old gets type 1 diabetes suddenly? At 60? Either it's chronic pancreatitis destroying the islets, or they got a tumor, a big tumor in the tail and the body. Okay, so a big pancreatic tumor can do that too. Most cases are going to present young. And what increases the risk is the HLAs. So if you get the right trigger and you have the right HLA, so DR3, DR4, having both of these together is a very increased risk. Now, the pathogenesis is we don't have insulin because your T cells are killing the beta cells. What do we call that when the T cells come into the islet and they start killing beta cells? We call that an insulitis. So if we ever did a biopsy of the pancreas, which you should never do in diabetes, but if they died at autopsy, what would I see at the beginning? You would see T cells coming in to kill them. Then the T cells will kill them. You'll lose the beta cells, and then it will heal with scarring. It'll heal with scarring. So eventually you just get scarring, and now you'll be a diabetic. Makes sense. So this is all about type 4. T cells coming in and killing it. Now these patients must take insulin. If they don't take it, they go into ketoacidosis and coma. So they got to take their insulin. They're absolutely dependent on it. Now, in terms of presentation, there are 2 ways diabetes present. It's either the 3 Ps, polydipsia, polyphagia, polyuria, or it's coma. It'll be a ketoacidotic, a DKA, diabetic ketoacidotic coma. Makes sense. Okay. Does anybody remember Halle Berry? Remember Halle Berry, right? Won the Academy Award for Monsters Ball. She was Catwoman. She was in James Bond. She was Jinx in James Bond. You heard of Swordfish? Catwoman, yeah, Halle Berry. Type 1 diabetic. Every day she takes insulin. And the way she presented, she started passing out. She was going into ketoacidotic coma, and she got diagnosed, and every day she needs to take her insulin. Isn't that interesting? So I wonder what her HLAs are. I'd love to check her HLAs. But I have a restraining order. I can't get within 500 feet. No, I got to stay away. All right, now they got to take insulin every day, or they're at risk for getting ketoacidosis. Now, for type 2, this is an epidemic. I'll be honest, when I was a med student, we used to call it adult onset. Not anymore. Our kids are obese now, so now kids are getting it too. So you can't call it adult onset anymore. We just call it type 2. It's most cases of diabetics. Now, it's because we're obese, right? It's a lifestyle. Now, over 10 million United States people have it. Half of them don't know it. There's a long period where you're asymptomatic and you just don't know. That's very dangerous because a lot of damage is occurring before you even get diagnosed. So a lot of people are asymptomatic for years. Now, risk factors are obesity. We're getting larger. Aging. We're getting older. And of course, is there MODY genes that increase your susceptibility? Yeah, there's also genetics that play a role as well. But usually obesity and aging, those are very important. Now, pathogenesis. We have insulin. It's not as high as it needs to be. So it's a relative deficiency. So it's high, it's just not high enough. So it's a relative deficiency. But in addition, not only do you not have enough, your peripheral tissues downregulate the insulin receptor. So you get peripheral resistance because there's decreased numbers of insulin receptors. Remember, there were tyrosine kinase receptors? They're downregulated. Now, good news, if you lose weight or if you exercise, they upregulate again. So that's why we want them exercising. We want them losing weight because you can kind of reverse some of this. All right, now this is often asymptomatic for a long period of time, but it's going to present the same way. 3 Ps in coma. 3 Ps, polydipsia, polyuria, polyphagia, or it could present with a very bad coma, HONC, hyperosmotic, non-ketotic coma, HONC. Now, I don't want a coma. You don't want a coma. All comas are bad, right? Why is this coma super bad? Why does it have a high mortality? Because hyperosmolar means the high sugar in your blood sucks all the water out of your tissues. You become incredibly dehydrated. Your brain shrinks like a raisin. You start to demyelinate. So this can kill you, this osmotic. So when we treat this coma, you can't just lower the sugar. If you just lower the sugar, they'll die. You have to lower the sugar while you're hydrating them like crazy. They're incredibly dehydrated. Type 1 is dehydrated too. These are incredibly dehydrated. Their brain is shrinking like a raisin. You don't want shrinkage of brains. So that's why this is a very dangerous coma with a high mortality. So treat the sugar level and give them fluids like crazy. Now, if we did a biopsy of the pancreas, which we shouldn't, but if you do, the beta cells are there. They're there. They're atrophic. There's some amyloid. This is the one that has some amyloid surrounding it, but at least the beta cells are still there. Now, you're supposed to change your diet and start exercising, lose some weight, but Americans can't do it. So what's the first drug we always start you on? We're going to start you on oral agents like metformin. That's the classic go-to initial drug, metformin first. Now, what if metformin doesn't lower it enough? Then use a second oral agent, your choice. You like glitazones? Sure. You like the sulfonylurea? Sure. Whatever you like. Start a second one. What if the second one does not lower it enough? Third oral agent. Now, if you've gone through 3 oral agents and you still can't control it, then you got to go to insulin. So I don't want to start with insulin, but you may wind up requiring insulin in really bad cases. Makes sense. All right, now so far I didn't teach you anything. Maybe we could teach you something with the pathology. Let's go there. Now for the blood vessels, we've mentioned already diabetes is a major risk factor for atherosclerosis. So if I ask you, how is Halle Berry most likely going to die in the future? The big killer of diabetics are MIs. Now, if it's not an MI, it could be a stroke because of the atherosclerosis. And she's also at risk for infarcting her sexy toes. If you're a toe lover, oh no, because they get peripheral vascular disease from the atherosclerosis too. Yeah, they'll see loss of hair, you get atrophy of the lower extremities, you get claudication, that's the peripheral vascular disease, and eventually get gangrene of their toes. Now, what about the kidney? Well, we already talked about the nodular glomerulosclerosis, the Kemal-Wilsons. That's a board favorite. Do a PAS thing, you'll see all those nodules. We talked about the arteriolosclerosis of the afferent and efferent. We talked about pyelo. Remember, they have a higher risk of pyelonephritis because they have a neurogenic bladder. They have a neuropathy. So they get cystitis. They wind up with pyelonephritis. Makes sense. Now for the eyes, this is a big cause of adult blindness, diabetics, big cause. Now